most of you. Let me see if I can. Okay. My name's Jennifer Leiding. I am an associate professor at the University of South Florida, but I also had the pleasure of training under Dr. Malech at the NIH and alongside Dr. Zerbe, who will be one of our speakers a little bit later on. And then I moved back to my home state of Florida in 2012 and have been an immunologist affiliated with the University of South Florida since then. So I'm going to spend the next, I think, 30 minutes going over sort of an overview of CGD, and then we're going to get into a little bit more of the sort of guts of all the different types of treatment and things like that. So this is a little bit more of a general overview, and then we're going to get into more depth about other things. So if you're not seeing that, it's because it's coming, but don't get anxious. All right. So I like to start presentations about CGD sort of on a positive note, just showing how far we've come. So this is a copy of the original report that was describing CGD back in the early 50s by Dr. Good at Minnesota. And I was paying attention out when people were getting lunch, and I saw a lot of Minnesota tags. So some of you might be from sort of the original group that was followed in Minnesota or have since moved there. Anyways, this report describes a 12-month-old boy who had recurrent lymph node infections and was eventually diagnosed with a chronic granulomatous disease. But interestingly, they term this disease fatal granulomatous disease of childhood, and that's because prior to all the technology that we have now and treatment, children almost universally died in the first few years of life or first decade of life without just from their infectious process. So obviously we've come a long way since then, and so we're going to kind of go over some of the reasons that's happened and what we are trying to do to cure this disease. So I've listed here sort of the major manifestations that CGD patients get, and this is relatively universal no matter what type of CGD you have. So susceptibility to infections, and that's specific infections, which I'll go into in a minute. The overreactive response to infection or to inflammation, forming what we call granuloma. Granulomas are groups of cells, immune cells, that form in the tissue and almost replace normal tissue or can impact the function of normal tissue. So they're not intended to be there. They're not intended to be there sort of for a long amount of time. In CGD patients, they lack the ability to really clear a granuloma effectively. We also see poor growth. This is really universal among immune deficiency, but specifically in CGD. There can be difficulty with wound healing, so patients who have had trauma to the skin or even surgery may have trouble with those wounds healing or closing. We see a lot of mouth sores and periodontal disease, so gum disease, mouth sores like ulcers, kind of like canker sores, and that can be really problematic in patients. Colitis is the fancy medical term for inflammation of the bowel. So a lot of people get diagnosed with either ulcerative colitis or Crohn's disease, but in fact have CGD. And so colitis is really reminiscent of CGD. This doesn't occur in every patient, but does have an increased predisposition in CGD patients. And then other autoimmune features or other autoimmune diseases can occur as a result of CGD itself and is just associated with CGD. So the problem in CGD is with the neutrophil, and so I put this slide up just so you can sort of see some of the different immune cells that we all talk about as immunologists, but also other patients maybe in the next room talking about a different cell. So in CGD, our sort of left, I guess it's the left for you guys, cell on the screen is a neutrophil. And neutrophils are, when we look at them under the microscope, what gives them their characteristics is this dark purple is called the nucleus, and it has this very lobed appearance. And then all the little dots throughout the cell are granules that make up the neutrophil and are important for killing certain types of bacteria and fungi. So out of all the cells that are here, your body makes the most neutrophils, constantly making them. They're made in the bone marrow, and then they're released into the peripheral blood. And you produce millions a day. They have a very short lifespan, and then I mentioned the granules. So they sort of get made, they go do their job, and then they're cleared out. once they're done doing their job. The bone marrow has the ability to start making thousands of neutrophils during acute infection and release them into the blood, really responding right away. When I talk to students, I usually say neutrophils are the Marines of the immune system. They're sort of the first responders. They go in quickly, and then other cells will follow behind. So if you think of, this is my schematic of what's going on in the neutrophil. So you have to think of this dark blue, the very big circle, as a cell, so a neutrophil. And then the light blue is sort of a cell within a cell, and that's called the lysosome, or the phagolysosome. And that is where the killing of certain bacteria and funguses occur. So again, big cell, and then sort of little cell inside of it. And the light blue is supposed to be the surface of the lysosome. So on the surface of the lysosome, when there's an infection present, all of these different components come together that I've labeled with the red and the dark blue and the purple. And these are the components of the NADPH oxidase system. So the NADPH oxidase system allows for the production of superoxide. So for those who don't know what superoxide is, you hear all these commercials about antioxidants, right? You're trying to kill oxidative radicals. Those things can be harmful in cardiovascular disease. There's a lot of different things that they're used for, but that's what they're referring to as superoxide. Now, people who take antioxidants don't get CGD. I'm not trying to say that, but that's the way you can think about what superoxide is. And so when that superoxide is made inside the lysosome, that's where the killing happens. So your neutrophil gets infected with something, some sort of bacteria. This complex comes together, it makes superoxide, and it kills said bacteria. Does that all make sense for the most part? Okay. So mutations in any 4 of these components gives you CGD. Now, they all have different features, they all have different inheritance patterns, but they all give you the same disease. So 4 different proteins, same disease. Okay, so a little bit about inheritance patterns, just so this makes sense to everybody. The 2 types of CGD that exist that we know of are X-linked CGD and autosomal recessive CGD. And if you follow this schematic, I'll start with the X-linked, which is on the left side. They're showing dad in blue, who is not affected. He doesn't have CGD. And then we're showing mother, who is a carrier. So she is got 1 gene that is mutated, 1 X chromosome that's mutated, and 1 normal X chromosome. And so when those 2 people have children together, when they have girls who are in the middle, you can see it's probably easier if I point right here. These are the 2 girls. They have a chance of having an unaffected girl. They have a chance of having a girl that's a carrier. And then so that's a 50-50 chance. And then if they have a boy, they have a 50% chance that the boy is unaffected and 50% chance that the boy is affected. So X-linked inheritance is typically passed from mothers to sons, and it's 50% with each pregnancy. So if you are pregnant with a boy, that boy has a 50% chance of having CGD. If you're pregnant with a girl, that girl has 50% chance of being a carrier for the same mutation that mom is a carrier of. Now, there are boys who have X-linked CGD whose mothers are not carriers, and that happens not that infrequently, and it has to start somewhere. So it's not always the mother who has passed to son. Sometimes it starts in son. The second type of inheritance is autosomal recessive, and that implies, for the most part, that each parent is a carrier for the mutation. So they have 1 gene that is normal, 1 gene that is mutated. And so if you look at their offspring on the bottom, the sex of the child does not matter. There's an equal likelihood that the child may be affected, and it doesn't matter if it's a boy or a girl. So in the case of autosomal recessive inheritance, your child has about a 25% chance of being affected, has a 50% chance of being a carrier for one of those mutations, whether it's from mom or from dad, and a 25% chance of not being affected at all, not having the disease and not being a carrier. So those are the 2 types of inheritance that we see in CGD. So to get a little bit into it, the diagnosis of CGD occurs in about 1 in 100,000 to 1 in 200,000 births. And this frequency or incidence can change based on birthing patterns. So we see some areas of the world where they have different marital practices, that incidence might be higher. In some areas of the world, it might be lower, but that's roughly about where it's at. The presentation's usually in childhood, usually in the first 5 years of life, but we have more and more adult cases being recognized, and I'll get into that in a little bit of why that might be going on. So getting back to our inheritance, the types of CGD, so the XL stands for X-linked and the AR stands for autosomal recessive. So what I have listed is the gene and then the protein that the gene makes, which, for purposes of this talk are essentially synonymous. And so the X-linked type of CGD is due to mutations in GP91 FOX, and it's by far the most common. So out of all the patients that have CGD in most of these natural history studies, it's about 70% of patients. And then, as I just discussed, oftentimes the mother or sometimes sisters in these families are carriers for X-linked CGD, and there is some manifestations of potentially being a carrier, which Dr. Zerbe is going to get into in a little bit. The autosomal recessive types, so there are many. And the first is, and by far most common, is P47 FOX deficiency, which happens in about 20% of patients. And then much more rare is P67 FOX and P22 FOX. There is, if you were paying really close attention to the diagram where it had all the big explosions within the proteins, there is a protein called P40 FOX, which has mutations in it that can cause CGD, but has only been described, I think, in 2 patients thus far in the literature, so extremely rare. Okay, so how do we diagnose CGD? So many of you, especially those older CGD patients or older CGD families, probably remember this test called the nitroblue tetrazolium test, and you may never forget it because it's probably the test that diagnosed you or your child. So when I say fallen out of favor, it means we often don't rely on it anymore, and I'll explain to you why that's the case. So if you look in the middle picture, that shows what neutrophils, when undergoing this test, should do when they are correctly making superoxide. You see this dye change to this sort of black color, and that indicates normal superoxide production in a person whose neutrophils are functioning normally. In a CGD patient, like an X-linked CGD patient maybe, which is in the top panel, you should see essentially no production of that dye. And then in a mother who might be a carrier, or is a carrier in this case, you see about 50-50, right? 50% of their neutrophils are expressing normal superoxide and 50% are not, roughly. The problem with this test, there's 2 problems. One, it's not always this easy. Very few people read textbooks. Very few patients read textbooks. So we don't always see this complete absence of dye. The second problem with this test is it's relying on somebody's eyeballs to make a diagnosis, and humans make mistakes. So they may not recognize that this looks like CGD, and there's many cases, hopefully none in this room, where women have been told that they are not carriers, and then they go on to have sons who have CGD. And so that makes this test fallible. Although it still works the majority of the time, there are better options now. And that better option is called the dihydrorhodamine assay, which really relies on very similar technology. It just takes the human component mostly out of it. So what we do in the DHR assay is we take blood from a patient, we put it into a machine, and that machine separates out the neutrophils. It then stimulates the neutrophils and looks for a color change, just like that NBT test did. And so you can see on the top graph, they're isolating the neutrophils. Once they're stimulated, this peak moves across the graph as the fluorescence sort of kicks in. And the machine can detect that fluorescence and quantify it. So if you look at the DHR for different types of CGD, so if you look at our X-linked, so again, before I get into that, let me orient you. The top of the slide is non-stimulated, so it has these cells have not been exposed to the stimulant. The bottom set of graphs is exposure to the stimulant, looking for that fluorescence. So if you look at the top all the way to the left, that's our X-linked CGD. So you're comparing top to bottom. So the top is not stimulated, and you can see once it is stimulated, there's no fluorescence. That peak doesn't move anywhere. It doesn't move to the right of the screen as it should, based on, I'm going to go back just so you can see. See how this one's moved to the right? That one hasn't moved at all. So that's consistent with X-linked CGD. If you look at those carriers, just like in the MBT test, we see two populations down at the bottom middle. We see the mutated population that has had no movement and no fluorescence, and then the non-mutated population that has moved and has some fluorescence. In those who have P47 deficient CGD, they often have some superoxide production, although be it not normal amounts, some versus none. And so we will see some movement of that peak or some fluorescence of that peak in a P47 deficient CGD patient. So what's nice about this assay as compared to the MBT is that it diagnoses CGD, but it also can give you a little information about the particular type of CGD the patient might have, whether it's X-linked or autosomal recessive, and then maybe guide genetic testing after that. Okay, so this is a review that we published several years ago that goes over different types of infections that happen in CGD. This is intended to be comprehensive, although I'm sure this list is growing. But what they universally have, I sort of separated based on the left side of the slide as bacteria, and then, sure. That's okay. Yep. This has been updated, we updated it in 2016, so there's a more recent version, but there are lots of case reports of unusual infections that come out in CGD. And so I think all of us can agree this is probably not perfect, but it does give a good guidance to the types of infections. It's more important, I think, as clinicians and patients to know the type of infections, not necessarily the specific bug each time, but the sort of characteristics of the infection that a CGD patient is susceptible to. So in the case of bacteria, the types that we see are listed on the left, and then in fungus, by far the most common is a fungus called Aspergillus, which is listed at the top. There's also certain locations that these infections tend to infect CGD patients. So you can see, for example, on the left-hand side, Staphylococcus aureus likes the soft tissue or lymph nodes, sometimes liver, etc. And so that can sometimes guide us as well. Aspergillus, for example, often causes pneumonia, can sometimes be as severe as in the brain, although that's less common, and then lymph node infections, and so down the list. So from that list, if you sort of want to think about the most common, or the way we teach clinicians, the most 5 sort of common out of that list are listed in red. So Staph aureus, Serratia, Burkholderia, Nocardia, and Aspergillus. And I've listed sort of next to them where these bugs like to infect. So again, for an example of Staph aureus, liver, lymph nodes. Osteomyelitis is the fancy word for bone infection. Bacteremia means that the organism's found in the blood. And then if you look at less common causes of infection, we've listed Salmonella and BCG. BCG is the tuberculosis vaccine that is used in developing countries to prevent tuberculosis, and it can cause infection in CGD patients. And then Salmonella. We tend not to see these as much in the United States. One, we don't give BCG vaccine in the United States, and then Salmonella is typically found in untreated water. And so we just have sort of better hygienic practices for maintaining water. And then others that are more rare are listed at the bottom. Some of them are kind of interesting. I always think at least the first one is, because I'm from Florida, the sort of second generation house of mouse, Chromobacterium. So that's a bug that's found in brackish water. Brackish water occurs when salt water and fresh water meet. So if you have a river, so I live in the Tampa Bay area, and we have the Hillsborough River that dumps right into Tampa Bay. So there's tons of brackish water there. So we have to really guide our patients not to be near that. And I'll get into that a little bit in a minute. So this was a report that came out of the NIH about 2 years ago, looking at the types of infections that CGD patients get. And there's a few, I think, learning points from this article. One, if you look at the upper left hand, really nobody is spared from infections, depending on what your type of CGD is. Those who have X-linked CGD get infections just as commonly as those who don't have X-linked. And it's showing sort of the breakdown. The other that's important is the type of infection and where it infects has changed a little bit over time, and that is probably due to prophylaxis. So we've limited the sort of less severe infections, but the more severe infections are still occurring with some frequency. But you can see, for example, on the most sort of bottom graph, Aspergillus primarily likes the lung versus skin, bone, etc. Whereas Serratia, which is the second from the top, tends to infect the skin and soft tissue. And so certain bugs like certain places. And these are just some pictures of patients and types of infections that we might see. So this is a little boy with a staph lymph node infection of the neck. That's over on the left-hand corner. And then this is an infection of the bone we call osteomyelitis, and it has actually eroded out through the skin. And then this is a picture of Aspergillus pneumonia. So this is what Aspergillus looks like under a microscope, you see in the left-hand panel. And this is a CAT scan of somebody's chest. So just to orient you, I don't know how many of you guys have ever looked at CAT scans, but they tell you right and left, right? That's the patient's right and the patient's left. You have to imagine this patient is laying flat, like their back is to the floor, their head is looking straight up, and they're going into a machine like this. So laying flat. And the best way to orient is this right here is a backbone. That's your spine bones. And so you can see in this, the black part on the left-hand side or the right-hand side of the patient is air. That's what your lungs look like in a CT scan. And the left side has no air. So the lung is being completely replaced by infection in this patient. And that's how severe that can be with Aspergillus. Some of the granulomatous complications. So I talked a little bit about granulomas. Granulomas, again, are abnormal tissue that develops, or a collection of cells that develop at certain places in the body in CGD patients. And so the top left, and I'm going to show you what normal looks like in a minute just so you can sort of have a comparison. The top left is somebody's esophagus, and so these are granulomas that are compressing areas of the esophagus. This patient, I'm sure, had a ton of difficulty swallowing. The one to the right of that is the stomach. So the stomach is emptying, and you can see the dye not going through at the end. And then the bottom is a picture of reflux from the kidneys. So just again to show you a little bit of normal. So the bottom left is a normal looking esophagus. When you swallow dye, it should look almost like a hollow pipe. And then this is what a normal stomach emptying study should look like. So here's your stomach, and the dye is going into the colon. And you can see that not happening in the picture over here. So just to switch gears a little bit, what do CGD patients need to avoid? So there's many different pieces of advice that we give our patients to try to help them avoid these types of infections. So the first is not avoidance, it's actually getting, is vaccinations. I get called a lot by primary care doctors about what vaccines can CGD patients receive. You can receive them all as you should. So every CGD patient should be vaccinated. Every CGD infant should be vaccinated just like any other normal child. The only vaccines they cannot receive are BCG, which is not given in the United States, and Salmonella typhi, which prevents typhoid fever and is given if you're traveling to certain areas of the world. So if I have patients that are leaving the country and they're going to the health department to figure out which vaccines they need to get, I tell them not to get that. And sometimes they need documentation depending on where they're traveling. The other three have to do more with avoidance. So it's easier to think of how to avoid something when you know why you're avoiding it. So one of our biggest problems or things we're trying to avoid in CGD is the inhalation of fungus. So fungus grows everywhere. If you're out in the environment, you see mold, mushrooms, mildew, all of that is fungus. And so we don't want our CGD patients inhaling that. So if you think about ways that can happen where these spores get brought up into the air in very large quantities, I've depicted some of it on this slide. So things like gardening or mulching, going on hay rides. If you're a little boy and you're going on a hay ride in the middle of fall, or a little girl for that matter, wood chips, raking, leaves, grass clippings, all of those have the ability to really lift fungal spores up into the air, allowing patients to inhale them and get sick from them. Construction sites and house renovations equally pose problems for mold spores getting brought into the air. when you're removing old drywall, things like that, that have mold hidden behind it, it has the ability to do that. So CGD patients should not be around construction sites. They shouldn't be living in a house that's being remodeled. They need to move away from that house if the house is being remodeled, those sorts of things. And then the bugs that I talked about before with the brackish water and freshwater bugs are very problematic in CGD patients and can be very deadly in CGD patients. So we don't want our CGD patients swimming in fresh waters, ponds, or rivers, and specifically brackish water, like I talked about with the saltwater meeting freshwater. They can swim in oceans, and they can swim in swimming pools. So as long as they're not fresh, as long as they're chlorinated swimming pools. Yep. Are you talking, referring to like the flu shot? The flu shot can be missed. There's no reason a CGD patient can't have them missed. The contraindications for that have to, at least from an immune deficiency standpoint, have more to do with T cells, so not this room. I think next door they probably have that problem, and underlying lung problems. So people who have asthma shouldn't receive the missed shot, or missed nasal, sorry. They should not receive it if they have asthma. Does that make sense? Okay. Okay, a couple other general measures for CGD patients. Obviously, nobody should smoke or inhale smoke. And I'm not just talking about tobacco. So we, I have many patients with CGD, and I ask this of all of them, and not everybody is as forthcoming. But especially in the age of medical marijuana, patients need to be very careful about this. Because if you think about what you are inhaling, it is a plant. And a plant can easily be infected with mold or fungus. So I ask my patients whether they're smoking marijuana. I'm not the DEA. I'm not going to report them. I just want to make sure they're doing it safely. So you shouldn't be doing it, but if you are, you certainly need to be careful that you're not putting yourself at risk. Obviously, you should be immediately reporting symptoms of fever, any redness at sites of, things that could be swollen lymph nodes or infected lymph nodes, and any soreness around a wound. And then CGD patients really should follow up with their physician. I would say, at least in my opinion, and I think in most, every 3 to 6 months, depending on how close you are to your physician and ability and access to care. And this is even when you're well, because it takes familiarity to recognize when something's not normal. And that's with yourself and with your physician. So if they don't know what normal looks like, it's hard for them to know what abnormal looks like. Okay, so now that I've talked about all the bad, let me focus a little bit on good. So the prognosis is that's not a typo, it's so much better. So it's significantly improved. If you think about where we've come in the last 60 years, our little children, our boys and girls, are not dying of this disease. They're living to be productive adults and have jobs, and we can owe that to a lot of things. One is better drugs. So, even 20 years ago, we didn't have the drugs we have now. Even 10 years ago, we didn't have the drugs we have now to treat some of these infections. Doctors are better at recognizing this, so there's earlier diagnosis and earlier intervention, and better recognition of what's going on. So we have better modalities. Some of it's human, your doctor is better. Some of it is we have a CAT scan machine now that can show your infection where they didn't have that 50 years ago. So, and we know now too, we've had a lot more data that have shown that your survival is very disease specific. The type of CGD you have dictates prognosis. And so this was a paper that came out about, it's been 6 years already, or 7 years already, in the New England Journal that showed patients being separated into quartiles based on the type of or the amount of superoxide they were making. And so you can see these different types of quartiles, and I'm not going to go into it now because I think Dr. Malech or Dr. Parikh may touch on this, on who we think about more curative therapy for. However, you can see even just the proportion surviving, right? Even if you're in this lowest quartile, by 40, there's 60% survival. That's still very good compared to the early 1950s. And so as we start, as I think as a field, we've all talked about how we have allowed for patients to survive longer. And now we have shifted our focus a little bit more, not just on survival, but on the quality of that survival. So what is life really like as a CGD patient? And this is fabulous and fantastic that people are living longer, but they want to have a good quality of life while they are living longer. And so unfortunately, I skipped over myself. So some of the things that might affect quality of life in a negative way are recurrent infections, frequent hospitalizations, children not growing well. And so, when we say poor growth, that doesn't just mean is your child tall. That means, are they developing normally? Are they walking when they're supposed to walk, talking when they're supposed to talk, eating independently, having normal behavior in school, learning the things they're supposed to learn that their peers are learning in a regular pace? Chronic medications, so having to take medicine every day. The idea of colitis, how much is that impacting people's quality of life? Are you having to run to the bathroom all the time? Are you comfortable? Those sorts of things. And so quality of life in CGD, unfortunately, there's not a lot of great data on it. This is a paper that came out from the NIH in 2004 that Dr. Malech was involved in, looking at cognitive function in patients with chronic granulomatous disease. This isn't really a quality of life study. It's more just looking at neurocognitive delays. And so in this study, they took patients and did neuropsychiatric testing on them to see what their IQs were and what their cognition was. And unfortunately showed that there were some significant cognitive defects with neuropsychiatric testing. Now, there was some selection bias in the study. These were all patients who were admitted at the NIH, being followed at the NIH, and at least I can say from experience, the NIH tends to get the sort of most severe cases. So there is some of that. You sort of have to think in the background. This is not affecting every CGD patient. So if we think a little more about quality of life, again, the only other major study that's come out is looking at quality of life in patients who are managed without stem cell transplant and then those who have undergone stem cell transplant. And is there a difference in quality of life for those who have undergone stem cell transplantation? And this was published in 2013 in the Journal of Clinical Immunology. And what they had these patients do was a pediatric quality of life inventory was filled out by the parent or patient, depending on the age of the patient. So I think if they were less than 10, the parent filled it out. If they were greater than 10, the child filled it out. And it was age-appropriate questions. The pediatric QOL inventory is a validated survey to assess quality of life. And at least in this study, children had what was considered a poor quality of life as assessed by their parents or by themselves as compared with healthy children. They had higher emotional problems and higher problems adapting to their environment, learning, growing, and all of this improved in patients who were transplanted. So this paper, at least by itself, is arguing that transplantation can at least improve quality of life in those who survive transplant. So as a plug for later, Dr. Dorsey, as you noticed, Dr. Dorsey was not giving the quality of life slides. She had a family emergency and so wasn't able to be here today, but she will be here tomorrow. And many of you may have, or if not will be, receiving a survey that's not just about this meeting, but is trying to address quality of life issues in CGD patients that's being put together in union with the IDF and the USID-Net, who are trying to prospectively gather information about quality of life patients for CGD outside of institutions where there might be a bias for the sickest of the sick or that sort of thing. So to try to get a more universal understanding of it. So she's going to discuss some of the preliminary results tomorrow, and then I think we'll give you a lot more information about when and if you may receive more. And so I would really encourage you to take the time to look at this, because it's hard for us to know how to help our patients if we don't know the root of the problem. And that's all I have for this sort of overview.
I just wanted to say one thing, because I didn't have the opportunity, but I wanted to share with you a story of a patient who I saw this past week, a mom who, and I talked with Stephen about this beforehand. When she learned that Mary Hurley had passed, she told me that, so I started seeing her son about a year ago, and she said, you know, I've been emailing with this woman. She's been so helpful. It's been just spectacular to have another mom who can identify with what I'm going through. When she learned of her passing, she told me that when she and her son were visiting us at the NIH, in between that period of time, she learned through social media that Mary Hurley was in the building. And she told me it was like a celebrity sighting for her. I mean, Julia Roberts might be good for some people, but she said it was as if I had seen a celebrity. I couldn't believe I was in the same building as Mary Hurley. And that just tells you the type of influence she had on families. And I just want to, again, just bring up that wonderful story from one of our patients. Okay, so I'm here to talk about CGD colitis, and I'm going to call it CGD colitis. A lot of people call it a lot of other names. They call it Crohn's disease, they call it ulcerative colitis, they call it inflammatory bowel disease, but it really is its own entity, and I'm going to tell you about it today. But before I get started, okay, good, I know how to move the slides. I need to explain to you what we're talking about, because we throw a lot of terms around, and we just loosely throw them around, and you need to know what we're talking about. So, your GI tract. When we talk about GI tract disease, we divide it into upper disease and lower disease. So upper disease, your GI tract, whether you want to think about it or not, starts in your mouth and ends all the way down there. So the upper disease, if I can get my arrow, starts up here. What you don't see is the mouth. There's the esophagus that Dr. Leiding showed you, the stomach, right? That's upper disease, and then here's the small bowel. There's 3 parts of the small bowel, which we won't go into fully, but then we have the lower disease. And the lower disease starts with the ascending colon, right? This is your large intestine, or your colon as people call it, your transverse colon, your descending colon, and it's so special we break it up into its own particular parts. It's sigmoid colon, rectum, and all the way at the bottom is your anus. So understanding what we're referring to when we talk is very important. Oh, I just went backwards. There I am. Okay, so what is colitis? Well, itis, anything that has itis at the end, appendicitis, tenosynovitis, lunchitis, it's inflammation, right? So anything that has inflammation. So colitis is inflammation of the colon. And gastroenterologists will call it Crohn's disease. And I will tell you, it is not Crohn's disease, but it does share some features of Crohn's disease. So Crohn's disease, separate from CGD colitis, happens throughout the gut, meaning that the majority of Crohn's patients have disease all throughout the mouth, the esophagus, the stomach, the small intestine, and the large intestine. But they have something unique in the fact that they have what's called skip lesions, meaning they have completely normal, healthy tissue in between these areas of ulceration. And they also get things like crypt abscesses. And I'll show you pathologically what that means, but it just means that they get abscesses in the tissue of their gut. CGD-related colitis is different. It's predominantly a distal disease, meaning that the majority of patients have problems down low. They get granulomas, and I'll show you histologically what Dr. Leiding was talking about when we say the word granulomas, because we throw around that term and it's in the name, but people may not know what it looks like. And then they get those same crypt abscesses that the Crohn's disease patients get, but they get them in the setting with granulomas. And they also get severe colitis in which those crypts are no longer useful and they actually become obliterated in the tissue itself. So what are the symptoms? What do you need to look for? So bloating, it can, we talk about colitis, but it's a large spectrum of illness. So it can be just bloating or early satiety. So your child eats, and then all of a sudden, over a gradual period of time, you notice that they're eating less and less, and they just complain to you that they feel full. More than 2 stools per day. So I'm being very generous here. I'm from the government. I'm a little contraindicated there, but I'm being generous. I allow you to poop twice a day before I start to get worried about you having colitis. Urgency, it's almost universal. People say, look, when I gotta go, I gotta go. I cannot wait to go to the bathroom. So, the rest of us, we have coffee, we sit, we read a paper. I'm gonna be sexist here. The men go to the bathroom with some type of journal article and they stay there for hours, right? The kids can't wait. I have patients who know where every bathroom is between their house and their place of work or their house and school. Frequency. That just means exactly what it says. You go to the bathroom a lot. And tenesmus. Tenesmus is a term that refers to when you feel the urge to have a bowel movement and they sit and they sit and they sit and they go, are you done? And they go, I just can't. I just feel like I have to have a bowel movement, but I can't. I gotta poop, but I can't. And then cramping. And then liquid stools. So your stools can be anything between formed and pure liquid. And then, of course, the worrisome things that most parents will react to is if there's blood or mucus in the stool. Again, you're allowed to have it occasionally, just not all the time. So what are the signs? What are the things we look for? We look for things like iron deficiency anemia. So when I suspect colitis in a CGD patient, I always check iron studies and I see how much iron are they losing. Because you can have blood in your stool, but you wouldn't necessarily see blood in your stool. Unexplained fever. So I have a small percentage of patients who, without any evidence of infection, have fevers, and the fevers respond when we treat their colitis. And then unexplained elevations in inflammatory markers. We talk a lot about what are the laboratory markers of infection. Well, we look at those same markers for colitis, but we do it and we rule out infection first. And then failure to thrive, and I'm going to show you. So this is a severe case of failure to thrive. And what we mean by failure to thrive is, so every kid, you go to the pediatrician and everyone gets plotted on the growth curve. What percentile are you? So here's a child who came to us when he was 8. This was him on his 75% growth. This is for his weight. And then all of a sudden his colitis got very out of control. And look what he did. He completely fell off his growth curve. Now this is a very extreme example, but this is what we're talking about. It's falling off your growth curve. You should not fall off your growth curve. Your child will choose a growth curve and stick to it. And when they fall off, it is a sign of problem. So who gets CGD colitis? Well, this is one area where there's no discrimination. So we've followed a total of 250 patients, and out of those 215 patients, 44% of them, so the rate of colitis is about 45% in the CGD population, regardless of your type of CGD, meaning that the autosomal recessive patients get it at the same frequency as the X-linked boys. The difference when you look at it closely is that the X-linked boys present with colitis on average by 5 years of age, where the autosomal recessive patients on average present with colitis in their late teens, early adulthoods. So the age of onset is a bit different based on your genetic change. And then where do you get it? And again, this just speaks to exactly what I was talking about. Almost everybody gets disease. Look at this, 70, 80, 90% of patients get disease very distal. So it acts a little bit like what people call ulcerative colitis, but the histology of it looks a little bit more like Crohn's, and that's what makes it difficult to treat. So what does it look like? So everybody knows when they come to us, you're gonna get scoped. And this is why we do it. And this is why we do it, because we've seen a lot of colitis. So this shows you the difference between mild disease. You see that there's a little bit of, it should be sort of nice, smooth, and creamy, if you will. You see sort of an exaggeration of the vessels underneath that shows you there's some inflammation. Moderate disease, you start to see sort of what we call friable lesions, or lesions that when you pass by it with a scope, they bleed easily. And then severe colitis really completely distorts your gut, and that's really where you get into a lot of trouble. And the problem in CGD colitis is that by the time you have symptoms, the pathology in the gut has gone on for a while. So there is a lag between when your tissue starts to have problems and when you actually start to have symptoms. So what does it look like when we take biopsies? So this, I just pulled this from the net because no one does things better than the internet these days. So this is not a gut, in case you're wondering, not that you can tell. This is a granuloma. It's a lot of cells that get together and don't know what to do. They know they're supposed to go there, but they don't know what to do. It's a little bit like teenagers, right? So these are tissue biopsies from patients of ours from the gut. And when I talk about crypts, and glands, this is a normal gland, right? This is one that's been completely obliterated. It's gone, right? These are glands that are supposed to secrete things into your colon and into your intestines. That's what helps make everything lubricated and juicy and, break everything down. The inflammation that infiltrates into that tissue causes the problem, and it can destroy the normal tissue there. So you can imagine it takes time to do that, and it takes time to heal. And what I tell every single patient is this is a marathon. This is not a sprint. It takes a while. Okay, so this is, I'm going to, we can do this because we can show you the most severe cases. So this is a patient of ours who had colitis diagnosed at the age of 17 when he presented when he was peeing air. So he's a boy, you're not supposed to pee air, you're supposed to pee, right? So he goes, there's something wrong here. And in fact, what happened, so when you do a CT scan, you can do really fancy things. and you can show people the air. And here is where his colon is, right? So this is his colon. You're supposed to have air in your colon. That's why people make those noises after they eat beans. And here's his bladder. You're not supposed to have air in your bladder. Your bladder is a closed system. And he had air that is, hold on if I can find my arrow again. He had air that was going down through his colon, taking the path of least resistance into his bladder and refluxing up into his kidneys. You're not supposed to have air go up there. And over time, that can be very destructive. So that just is the air that shows you the air. It looks like a balloon. This is a CT scan where you can actually see the communication between his sigmoid colon and his bladder. And this took years to occur and hasn't yet closed. Okay, so how do you look for colitis? Well, there's only one way, right? So I can tell you the signs, I can tell you the symptoms, but there's only one way to really prove it, and that's to do a scope. And when we scope folks, we scope them both from above and from below, because the therapies are different based on where your disease is located. So I did say the majority of people have distal disease, but there are patients who have some upper GI disease or just gastritis, right? We ask a lot of our kids. They take a lot of medicines. We can cause problems that way. So we scope you, we do a full endoscopy. So we go from both ends. We're using different scopes, don't worry. And if you don't have colitis, great. We love that. There's a big party. If you do have colitis, we have a multitude of different approaches that we use, and we try to be very systematic and very methodical about it. And what you'll notice is if you have mild disease, we start you on local therapies. So 5-ASA, you might notice that as aspirin. It's basically aspirin for the gut, but it gets released locally in the gut, meaning that you're not getting it through your bloodstream, but actually just in your gut itself. And what I want to point out is that moderate to severe disease, we take these therapies and we add to them. So you don't leave with less medicine, but you leave with more. And the reason to do this is because the first medicine almost everybody uses in CGD is prednisone. And prednisone long-term isn't a good solution. So we add things called steroid-sparing agents to the other therapies that we'd use for local disease. And then we follow them up, and we follow people fairly closely. So really, the golden egg here is what to do with refractory colitis, which is extraordinarily difficult to treat. So almost everyone, again, we induce with prednisone, and we try to induce remission with it. But again, prednisone is not a good long-term agent. And I don't care what the gastroenterologists say. When they use prednisone, or budesonide would be another name for it, that isn't supposed to be systemically absorbed, you saw those pictures of the gut. That was a breakdown of tissue. The kids absorb those steroids systemically. And you will wonder why, on a drug that they're not supposed to absorb, their face gets all puffy and they eat so much more, because they're systemically absorbing it. And when they're on an azole, like itraconazole, posaconazole, voriconazole, see the end there? It's like itis, azole. Their steroid exposure is much higher because it changes the metabolism of the steroids. So we work very closely with our gastroenterology colleagues, but we do not allow them to drive the ship, because we know, and you know, CGD better than they do. Okay, sorry, I'm going to get off my soapbox there for a minute. All right, so what can you do? Well, we induce with prednisone, and then there are a variety of other options, some more risky than others, and we have tried a variety of different agents, both biological modifications, meaning that we're trying to modulate the immune system and the way the immune system works, as well as very straightforward and more simple things like an elemental diet. Okay, so why do I talk about prednisone, and why do I care? So, look, your child, if I took 60 milligrams of prednisone a day, I would get so much more accomplished. My house would be so much cleaner. I would have every lunch packed a week at a time. Everybody feels better on steroids. Just keep that in mind. But long-term steroids have consequences, and I'm showing you that, there are a lot of pros, right? Quick onset, easy to use, you feel great. The problems are that, one, steroids impair your neutrophil function, so you can increase their risk of infection. But there are long-term effects, and the long-term effects are best displayed by this. Look, you don't have to be a radiologist. This is a normal spine. Bright is bone. This is not a normal spine. There's much less brightness. And these really, really bright things, those are injections that a orthopod had to inject because of compression fracture related to long-term steroids. It is a problem. And so finding something to get these kids off of prednisone is really the golden egg. Okay, so what are the medications? Like I was saying, the mesalamine or 5-aminosalicylic acid, that's like aspirin. They're anti-inflammatories. They sort of calm the tissue down locally. Here are all the trade names. We almost always talk in generics, but you guys know them by the trade names, and this is the drugs the names that everybody tosses around. And then there's a lot of different ways that you can get it. The most common, and really the most popular by far, is the enema that almost everyone asks to be placed on. But actually, it is effective. It really is, but it is not fun. But it is effective, and there are times in life where we do things that are not fun, taxes. But we know we have to do them, and in the end, it is worthwhile. So if they only have really distal disease, the enemas are the best thing. No pill you take works its way all the way down there to be effective. What are other medications? So these are the steroid-sparing agents, azathioprine or Imuran. It's a 6-MP base product, so it's an immunomodulator. It will be immunosuppressive, but not enough. We have a very long history at the NIH using it. We haven't seen an increase in infections. This is the golden key, right? Can you suppress the immune system but not cause more infections? That's what you're trying to work for. It requires some monitoring of enzymes. You have to have certain enzymes to be able to break down the drug appropriately, and you have to check levels. So we have folks get their bloods drawn when they're not being seen by us and at home to make sure that the levels are appropriate. So what are the pros? It's very safe. We don't believe it causes increased infections. You can check levels, meaning that for me, in the teenagers, I can actually see if they're taking it. Right? I know young kids, for the most part, who have parents, mothers, fathers, they're taking it because someone's standing over them giving it to them. But the 18-year-olds, they're a tricky bunch, and they will tell you that they're taking it, but they may not be taking it. And the easiest thing to do is check a drug level. And you could just go, look, I'm confused. You say you're taking it, but there's no drug in your system. Can you explain that to me? So what are the downsides? It takes 3 months to have full effect, meaning that you have to be on prednisone, and we slowly taper the prednisone over the time that the levels of the azathioprine go up. So it takes time to affect that inflammation in the gut. And there are potential toxicities, and this is why we get bloods checked. We get liver function tests, and we get complete blood counts looking at their white count. Other medications, so these are the biologics that you've been hearing a lot about. So the one that is very commonly used in the gastrointestinal community are the TNF-alpha blockers, and these have a variety of different names. That famous golf guy advertises a lot of them. I don't remember what his name is. You can see I'm a sports person. But this is the problem with the TNF-alpha blockers. In CGD, they can be effective just like they are in Crohn's. However, we've had 2 deaths despite people being on optimal prophylactic therapy. And 2 deaths was more than we wanted to take. So we avoid the TNF-alpha blockers in CGD patients. We have had some CGD patients get referred to us who had gotten TNF-alpha blockers years before they got referred to us, and they did okay. And there's no saying that they can't do okay, but when you do it, we do a study for a reason, and when we do a study and people die, that's a problem. So what other medications are there in terms of the biologics? Well, vedolizumab is one of them. That's a TNF. It's an alpha-4 beta-7 integrin inhibitor. Okay, so what does that mean? It basically is a drug that binds to the cells. So cells need to bind to tissue to work their way in. It's like a lock and a key, right? And so it prevents that lock from going into the key and preventing the cells from getting into the tissue itself. One of the other drugs we're considering writing a protocol for, actually we're in the process of writing a protocol, is giving ustekinumab, which is something that we've used in another primary immunodeficiency that seems to have good activity in vitro, meaning in the laboratory, but we haven't used it in people yet. So this is our trial using vedolizumab in patients with refractory CGD colitis, and what I'm going to show you here is you have a variety of different types of genetic mutations causing the CGD. Here are the adverse events that we noted while they were on it. So this pneumonia was diagnosed radiographically, so to talk to your question, they diagnosed it with an X-ray, but they never biopsied it and just gave her some antibiotics and she got better and they didn't repeat the chest x-ray, and so I don't know. So sometimes it's a little difficult to know what's going on there. And then what I'll show, I can find my arrow. This is the HBI's, the Harvey Bradshaw Index. It talks about quality of life. How many bowel movements a day are you having? How fatigued are you feeling? How much abdominal pain are you having? And so higher numbers are bad, lower numbers are good. And so if you look across the board, people had higher numbers and they went to lower numbers, but nobody went to 0. So vedolizumab was useful, but over time, in almost every single patient, its usefulness wore out. And it's unclear why that is. It is a foreign antibody, meaning that it's possible that your own body can make antibodies to the drug and block the drug from being able to work, I think it's a very good bridge to the next therapy, and whatever that next therapy is, whether it be hematopoietic stem cell transplant or something else. So what are the other options? Well, I'm going to put a small plug in here for a protocol. There's 2 protocols are rating at the NIH. One of them is an elemental diet. So what is an elemental diet? Well, if you think back to when your kids were babies and you gave them formula, that's what an elemental diet is. And it talks about, we know that in Crohn's disease, you can put Crohn's disease patients into remission by giving them an elemental diet. And I have to tell you, I have patients who love their wings just as much as anyone else, but they will tell you, man, when I eat that McDonald's or fried chicken or KFC or Chick-fil-A, my colitis flares. Because, well, besides the obvious reasons, those are things that are very tough to digest, right? So an elemental diet is something that's made for kids. It comes in a variety of flavors, so it's not completely bad. And you can go on it. So we're going to start a trial. We go on it for 2 weeks. If your symptoms improve, and your symptoms typically start improving within the first couple days, then you can stay on it for 4 weeks, and then we slowly, gradually add back foods. So that boy that I showed you a while ago with his growth curve, I don't know if I can do this, but the growth curve, he went on an elemental diet for 2 months. He is now what we almost call a very healthy boy, and has exceeded where his growth curve was and just graduated from middle school. I'm not sure if he's here. I thought he was going to be here today. The other thing that we've had some experience with, but we'd like to open a protocol for, is to do stool transfer. So when you think about, stem cell transplant, this is not what we're doing there, but it is a little bit similar. So this is taking stool that is normal, healthy donor stool, and again, sort of looking at, so why should the elemental diet work? Is it something about the interaction between the stool and the lining of the gut? And so looking at transferring healthy stool into a colitic bowel to see if that would help. And in mice, although I agree we're not mice, it does seem to be helpful. And then transplant, and I believe someone else is going to be talking about transplant. We know from the data in transplant, when you go into transplant with colitis, and I would say controlled colitis or better controlled colitis, your colitis can be cured through transplant. We don't know yet if gene therapy cures the other inflammatory complications of CGD. I think it's too early to tell that. So what's the bottom line? No pun intended. Your residual superoxide production is unimportant in CGD colitis, meaning you get it across the board at about the same rate as everybody else. There's a lot of options out there for therapies, but it is a marathon, not a sprint. The prednisone makes you think it's a sprint, but it is a marathon, and it is not without more pills. And I'm sorry to say that, but right now we don't have the magic bullet, but we are working hard to figure it out. It's unimportant in overall survival. That is important for you to know. It does not affect their overall survival, the colitis, but it sure does affect their quality of life. And you can look around the room at the kids who have colitis, and it can affect their quality of life. So I'm giving another talk, but I'm going to do the acknowledgments here because I put it in this talk and not the next talk because I didn't want to just give you the same slides twice. But I could not do what I do without my case manager and my research nurse, Samantha Kreutzberg, Janine Daub, who's the nurse practitioner, Dr. Theo Heller, and all the GI fellows who we work closely with. And I would say, again, I think is best managed by folks who know CGD in conjunction with a gastroenterologist. And of course, everyone in the Holland lab and the neutrophil lab. And most of all, we could not do what we do today without all of you. And I don't think you can underestimate what forces of nature you guys are. Questions? Yes. Sulfasalazine is commonly used in kids, especially young kids, and it's sort of the topical aspirin for the gut. Mm-hmm.
Are all the medications in pill form, or do they have also liquid?
No, a lot of them aren't. So a fair number of them, like mesalamine, that only comes in a pill form in the way that it's compounded. There are some medicines that can be used in liquid form, but it is tough. The younger kids are a little tougher to get medicines into overall. But there are some liquids, and there are some, we have some patients have worked with local compounding pharmacies to have a liquid or a pill compounded into a liquid for them. Okay, so I don't want to exclude the sisters, but let me tell you about the moms. So they asked me to talk about the X-linked moms and the X-linked carriers with CGD. And this is what we think about in terms of moms and what they have on their plate on a day-to-day basis, right? You're happy if you get to sit down, you get your clothes on, you get showered, but in fact, moms caring for kids with PID and caring for themselves, well, that's a whole different ball game, right? A whole different ball game. So let's talk about X chromosome inactivation to understand why the carriers of CGD, so this, I'm going to be very specific here, these are the X-linked carriers of CGD, not the autosomal recessive carriers of CGD, just the X-linked carriers of CGD. So this is the symbol for a boy, right? So they get one X and they get one Y. They don't get a choice, right? So women, we get a choice. We get two X's. And in every cell, we inactivate one X so that only one X is expressed. We're very efficient that way. We don't want to be redundant. So you either inactivate the CGD X or you inactivate the healthy X, right? And so either the CGD X is the bigger one expressed in the cell or the unaffected X is the bigger one expressed in the cell. And that changes your DHR in a variety of ways. So that this is a normal DHR, so this is just what Dr. Leiding told you about. If I can find my arrow again. This is your amount of fluorescence down here. This is your number of cells. When you stimulate the cells, they all go from the negative to the positive. So shift is good. This is what happens when you're a CGD patient. You get stimulated and they all stay here. And this is what a carrier looks like. They have two separate populations of cells. It's not like they're wishy-washy. They have two distinct populations of cells. They have a population that acts like a CGD population and a population that acts like the unaffected population. So the term that we throw around is lyonization. What percent lyonization are you? And the percent lyonization is based on the percent of healthy or unaffected X's you express in every cell. And so we do that DHR test and we look. So this percent of cells in terms was 72%. So that means the mom or the sister is 72% lyonized. Here, the percent lyonization is very small, and it's only 3.8%. So that is a highly lyonized carrier. And that's when we throw around that term of highly lyonized. So we've collected about 185 women who who carry the gene for CGD, and we've plotted them out from when we have mothers and daughters. We separated them out, and then we had daughter A and daughter B. And what we looked at was, can you predict the percent lyonization of the daughter based on the mom? And what this shows you is there's no correlation. It's just willy-nilly. You can't predict it based on the mom. But in the few families we follow that have sisters, in fact, they are correlative. So the sisters are more closely tied than the moms and the daughters are. So that prediction, if you're a mom, you go, well, I have a daughter and I'm not highly lyonized, so she won't be, not quite right. So this is just we follow two sets of twins at the NIH, and just looking at the percent lyonization over time, it changes in tandem with each other. Now these are identical twins, these aren't just siblings, they're identical twins, and in fact their percent lyonization changes with each other over time. Okay, so it is what you would expect is a bell curve. So I think I would tell you that, as we talk about referral bias, we tend to get referred to a lot of patients who have infections, and then we discover that they're a carrier. But in general, it's a bell curve, meaning the majority of people have a percent lyonization of anywhere between 50 and 60%. And then, there's people up here, and then there's people down here. So where do carriers get infections? Well, again, just similar to the boys, they get the most common infections that happen in the lungs, and you work your way down. So they can get skin abscesses, they can get lymphadenitis, and they can get bony infections. So your susceptibility to infection is directly related to your percent lyonization. So if you have less than 10% cells that less than 10% of your unaffected cells are expressed, then you are at risk for the same infections that the boys can get. And so we recommend prophylaxis. At minimum, we recommend antibacterial prophylaxis with Bactrim. Antifungal prophylaxis, that's a little bit less clear. And the reason is because we tend to get referred patients who have fungal infections, they're highly lionized carriers. Is it an exposure, meaning that they go out and go mulching one day, or is this something that they just came upon by chance? And antifungals aren't as benign as the antibacterials, and so itraconazole would be the antifungal of choice, just like in the boys. There's no data for using interferon gamma in the carriers, and we don't use it or recommend it at that point for that reason. So the gray zone is if you're a carrier and you have between 10 and 20% lionization, because we have documented infections in carriers between that period of time, but in general, unless they've proven themselves to be someone who gets infections, not just sort of everyday ear infections, but CGD infections, we don't necessarily automatically prophylax them. So what else can happen to you? I know. So autoimmunity. So this is what we see more commonly. The rates of autoimmunity is 15% higher in those women who have the CGD gene than those women that don't. So autoimmunity in the United States is higher in women than it is in men. So they have higher rates in general just by being a woman. One of those lucky things. But the carriers, the X-linked carriers, actually have higher rates of autoimmunity. And the number one autoimmune manifestation is discoid lupus. Now, don't confuse it. It's a terrible term. Discoid lupus is a dermatologic problem. It is not lupus, but it just has a bad name associated with it. So it is a sun-sensitive rash. It can get blistering. It can be unsightly, and it can be it can scar. So it can happen across the bridge of the nose, on sun-exposed areas, things like that. Granulomatous colitis, so we have seen carriers with CGD colitis. We've seen carriers with Crohn's disease too. So keep in mind that autoimmune diseases are higher in women than in men. But histopathologically, meaning that the tissue biopsy looks just like the CGD colitis. And then we have seen lupus hypo or hyperthyroidism. Again, that is common in the female population, but more common in carriers. So this graph is really just meant to show you something, and it's meant to show you that your percent DHR, right? So here's the lower percent DHR, here's the higher percent DHR. So the lower percent DHR, your risk of infection or your probability of getting an infection is much higher. But if you notice, your risk of autoimmune disease is irrespective of what your DHR is, meaning that there's something special about just carrying the gene in terms of autoimmunity. So overall, your risk of infection, again, correlates to your percent of unaffected cells that are expressed. The lower the percent that are expressed, the higher your chance of infection. Less than 10%, we would tell you you need to take prophylaxis just like your sons. And they will be very happy that you have to get stuck and you have to take pills too. It's going to be a bonding experience for both of you. And your risk of autoimmunity, it's 15% higher than the general population. So you just sort of keep that in mind as you go through your life. It's not correlative to the percent of your unaffected or affected cells. Remember that graph. It has nothing to do with your percent DHR, just about carrying the gene itself. And the skin, it's really the most affected point, and that's the discoid lupus. So I think we've come a long way in understanding both CGD and trying to now understand the carriers of CGD, but we've got a long way to go. Okay.
All right, so just to get back on track, I'm going to spend the next time talking about antibiotics and interferon gamma. However, I wanted to relay a question that I was asked on the break that I think is an important question and we should answer to the group. So when I gave my talk, I talked about the presentation of CGD occurring or presenting typically in the first 5 years to 10 years of life. So the question I was asked was whether somebody can develop CGD as an adult. And so I think what wasn't made clear by me specifically is that this is not an immune deficiency that happens later. You're born with CGD. And so if it is diagnosed as an adult, it doesn't imply that you did not have it as a child. It just was not diagnosed as a child. So I just wanted to make that clear. I think it's a very important question and maybe wasn't clarified earlier. Okay, so moving forward, I am going to spend the next probably 20 to 30 minutes discussing the use of antibiotics and the use of interferon gamma in CGD and what it's there for and what it does. So just a little bit, I think this is kind of kismet to what Dr. Zerbe was saying, is we need to understand the language a little bit of what your physician is intending and what also these things are intending to do. So we talk a lot about prophylaxis and treatment in immune deficiency, and this slide really applies to any immune deficiency, not just CGD. But what the difference between prophylaxis is and what the difference between treatment is. And basically the difference is the goal, what you're trying to achieve. So prophylaxis, you're really trying to prevent infections from coming. You're trying to prevent the frequency of them or decrease the frequency of them, and you're trying to make them less severe when they do occur. So instead of being life-threatening, maybe it's a 2-day hospitalization or something like that. You also you want to prevent the infections your patient is susceptible to getting. So in CGD, I listed that sort of giant spreadsheet of infections. Those are the infections we want to prevent. We're not trying to prevent everything under the sun. We're not trying to prevent the flu or the common cold. We're trying to prevent the infections that CGD patients get that can be life-threatening. And often these medications, sorry, there's a typo, that's not loaf-threatening, it's life-threatening. And these medications are often given orally. This is not something that we're typically giving through an IV. This is something you need to be taking every day in your routine life, just like brushing your teeth, changing your underwear. You remember to do it all the time, hopefully. And then treatment, again, the strategy is different. The treatment is treating an infection. So something has infected the patient that needs to be eradicated. Often, at least in the case of CGD, these medications are given intravenously, at least initially. Sometimes this is in the hospital, sometimes this is at home. And the length of treatment and the route of treatment is really case-specific, specific to the patient, specific to the bug. But at least in the case of CGD, is often initiated IV and then switched to an oral route at some point. Now, the medication may be the same as your prophylactic medication. So I have a lot of patients who say, why am I still on the same drug? I just got this infection while I'm on that drug. Well, sometimes that's still the best drug for that bug. And maybe we need to just increase the dose or give it in a different way. Maybe give it IV instead of orally because of the absorption of that drug. And then sometimes the prophylactic medication is stopped and the treatment medication is replacing what the prophylactic medication was preventing. So it's treating an infection but also preventing, maybe a list of more infections. So do those concepts make sense to you guys, or do you have any questions about that? Okay. So again, the laundry list of CGD infections. So again, I'm trying to show this really to really guide the way we think about this, that we are trying to prevent these infections. So because I have CGD patients who come in and say, I'm still getting sick all the time. Well, I can't help that rhinovirus is in the community or something like that. That is not the intent. The intent is to prevent these kinds of infections from infecting the places CGD patients sort of choose to become infected with, or don't choose, but it occurs. Okay, I'm going to skip over this just for the sake of time. Again, pictures, same pictures as before. I was thinking maybe there would be different audience at each of these talks, so I apologize for the redundancy. My kids are younger than Dr. Zerbe's, so I'm much less efficient, I promise, with the mom personality. So staph lymphadenitis and the bone infection, again, this is a major bug that we're trying to prevent with the prophylactic medications that we use. Again, this is the aspergillus picture showing aspergillus pneumonia. And then one picture I didn't show in the previous talk but is in this talk is a picture of liver abscesses in CGD. So this is a picture from Dr. Holland at the NIH, but if you see, again, the CT scan, remember the way this is oriented is the patient is laying on their back, so the back is to the ground, head is to it's like lying in a bed, head is to the sky, and your head is towards this wall, and your feet are towards the doors. So you can see the white at the back is the backbone. And so this particular organ is the liver. So this is, a pretty generously sized liver. However, if you see sort of this color of gray, kind of where I'm pointing the mouse, that's what most of the liver should look like, with the exception of the blood vessels that we see coming through down here. So for people who look at this a long time, it's more obvious. Those who don't, What doesn't belong in this picture is this giant nodule right here. So that's a weird looking color in a liver that shouldn't look like that. And so this is a liver abscess. And what's different about liver abscesses in CGD patients versus other patients who get liver abscesses is that they get surrounded by all of that inflammatory tissue that Dr. Zerbe showed you a picture of. And so when you take these liver abscesses out, they actually look a lot more like a tumor, like this giant sort of dense tissue versus what most of us think an abscess looks like, which is, you know, pus or liquid inside of the organ. So these are the types of things we're trying to prevent from happening in our CGD patients with the use of drugs or medications. So what do we need to take to prevent the things that CGD patients get infected with? So the first is antibiotics, the second is antifungals, and then the third is immunomodulation. And that's a fancy word, but it means changing the immune system or modulating the immune system, directing it in a way that we want it to work when it isn't working the way that we want it to work. So antibacterial prophylaxis. So the way the majority of these things came about, with the exception of, well, I shouldn't say with the exception, at least in the case of antibiotics, was more anecdotal. So in medicine, what we really like for a medication and what the FDA, at least in 2017, demands is placebo-controlled blinded trials. So what that means is half the patients get placebo or nothing, half the patients get the drug, and nobody knows what they're getting. The doctor doesn't know, the patient doesn't know, so that you can rigorously see if the medication is actually getting the effect you want. And so in the case of immune deficiency, specifically in CGD, doing those types of studies can be very cumbersome and hard because it's hard to group that many patients in one institution. The NIH has been very successful at doing it, but not every other institution can do that. They maybe take care of a handful of patients. And so to do that kind of trial in that institution would be very difficult. And so in the case of antibacterial prophylaxis, there was no double-blinded, placebo-controlled trial. And at least in the case of antibiotics, we also can't go backwards. Now, knowing this data, we can't do that kind of study and prevent a group of patients from getting antibiotics because that would be unethical. So now that we know this, we've sort of like dug our own grave. We can't go backwards to try to do as rigorous of a study as we may have wanted to at origination. That being said, there's lots of good studies that have shown that using antibiotics do prevent bacterial infections in CGD. And so the antibiotics that we use are, this is the fancy acronym for trimethoprim sulfamethoxazole, which in my next slide I'm going to show you all the different names for that. But at least in the study published in 1990 that I referenced below, they were able to show that using this drug daily in CGD patients reduced the frequency of infections from bacteria from 1 every year to 1 every 3.5 years. Now the caveat to that is that's not 0. That doesn't mean you never get an infection. That means it's not as frequent and not as severe, which remember when that very first slide I showed you was what our goal is with prophylaxis. They also were able to see there's less skin infections and less staph infections. So using trimethoprim sulfamethoxazole at least has the majority of its activity in helping prevent staph or Staph aureus infections. This is lifelong. So when we're putting our patients on this medication, you're not going to get to stop it. This is forever. So every day, when you wake up and brush your teeth, you get to take your trimethoprim sulfamethoxazole. And then the dose is specific. In kids, we can give liquid. In adults, we can give pills. And this particular drug is very cheap. It's been on the market for a very long time. So the other names for trimethoprim sulfamethoxazole are Bactrim or Septra. You guys probably are quite familiar with it. And like I said, it's, at least in Florida, I can get this drug for free at pharmacies. It doesn't even require insurance. So this particular medication is quite easy to get. So what happens if you're allergic to Septra? So Septra is one of those sulfa medications. You hear people being allergic to sulfa. So what can you do? So I have the benefit, I think, unlike my two colleagues here, of also being an allergist. So if a patient is allergic to Septra, we can do this procedure where we desensitize the patient to the medication. And what desensitization means is we're teaching your immune system not to react to that drug. And we give it in very small amounts, and it's daily. The problem with desensitization is you can never stop it. If you miss a dose, like I just forgot, you have to be re-desensitized because you could react again. So that's the problem with it. But there are alternatives to Septra, and the ones that are more widely used are decloxacillin, ceftonir, and Levaquin. And so, and these classes of medications, I just listed a few examples from them. All of them have their issues. So quinolones, for example, you hear a lot about stories of tendinitis or tendon ruptures with quinolones, with ciprofloxacin and levofloxacin. Levaquin's other name is levofloxacin. The original publication that showed that was actually in beagles, and clearly we're not beagles, but I do, at least in my experience, I have seen this with Levaquin, and so it's a problem, and it's not a perfect drug, but it is a good alternative. Okay, so antifungal prophylaxis. So this is one where we were able to do one of those rigorous placebo-controlled double-blinded trials that I just talked to you about. And so this was a study that was done by Dr. Gowan and Dr. Malech at the NIH and others who took 39 patients and assigned them to either placebo or itraconazole. And then they were switched annually, so it was a crossover study. And so in this study, the only infections that occurred in the itraconazole group were in this one patient. And if you read the text of the study, this patient was not compliant, so he was not taking the medication as prescribed by the study. And then the other fungal infections that occurred were only in the placebo arm, showing that this drug is very effective at preventing fungal infections in CGD patients. And so, again, the dosage is weight-based, also age-based. If you're less than 12, you get a certain dose. If you're over the age of 12, you get a higher dose. And so that's maintained. What's interesting about the azoles, and I wish I had put a slide in here because it just came to me now, is that insurance, one, does not like to pay for these medications. They like to pay for the lower azoles, so things like fluconazole or ketoconazole. Fluconazole is the same as diflucan, and then ketoconazole is used a lot for kids who have fungal, like scalp infections. They make ketoconazole shampoo, that may be where you've seen it. Neither of those drugs have activity against aspergillus, and so it's pointless to take them in CGD. You really need the higher generation azoles. So itraconazole is one, voriconazole, like Dr. Zerbe alluded to, and then posaconazole, which I'm going to show in a second. Okay, so that's that. So I get this question a lot. Why are some patients on voriconazole or posaconazole or itraconazole, and why am I not on the other one? Why should I be on this one? And a lot of it has to do with access to care and what you started on and the evolution of disease. So voriconazole and posaconazole, I think by those of us who do this for a living, are often started during acute infection. You've developed a fungal infection while on itraconazole, and your doctor has escalated therapy to try to eradicate that fungus better. Because of the idea that maybe you've developed it on the prophylaxis that you were on. And so once that happens, that escalation of care, it's very infrequent where we go backwards. So you don't see a patient that typically gets treated with voriconazole that then goes back to itraconazole. It occasionally happens, but it's unusual. So you're continuing sort of continuity of that escalation. Now they may back down on the dose, right? The voriconazole dose for the treatment of the fungal infection might be significantly higher than the prophylactic dose, but you tend to stay with that medication. So voriconazole can be given IV or orally, and its big bad side effect is that it can cause increases in liver enzymes, and so people who are on it need to have those liver enzymes monitored. We accept some elevation, but if it gets too high, sometimes we have to change the medication. Posaconazole is given orally. It's usually about 3 times a day, and it's a little bit harder to maintain therapeutic levels. I tend not to use posaconazole a lot, and that has a lot to do just with where I'm at. So in Florida, this is a very hard drug to obtain, and so I tend to rely more on voriconazole and itraconazole, but that, again, is very institution-specific or, in reality, insurance company-specific. Okay, so a little bit about monitoring for infections. So I say this too, so I have my little soapbox line in here that I'll show. If I had a nickel for every time a CGD patient says that they feel fine. So I get called a lot. My patients live really all over the state. Florida is a strange sort of state because there's not a lot of access to care. And so patients travel from very far to see me frequently. And I have to rely on more community physicians to see them when they're sick. And so patients will call and say, I have abdominal pain, or I had a fever, or whatever, and I send them to their local ER. I would say almost 100% of the time, that physician who's seen them, who's not an immunologist, or the patient themselves sometimes say, I'm fine, I just want to go home, and that's not the right answer. So the right answer is you have to look. If you don't look, you won't find. So in CGD, patients are often carrying around infections that in a person who did not have CGD would make them feel terribly ill. But the lack of immunity in CGD is allowing you to not feel terrible. You feel okay, you're going to school, you're doing your job with a whopping pneumonia until you don't feel okay. And so our goal is to find it before you sort of hit that wall. So what we do to monitor for infections is we do blood work, and we look for these acute phase reactants, what Dr. Zerbe referred to. Ferritin is one of them, but ones we rely on more frequently are ESR and CRP. These are really good markers of something going on. They're not specific at all, but if a CRP goes from normal to very elevated in a CGD patient that has a fever, I think all of us would agree that's infection until proven otherwise. So it's a really good marker of just sounding the alarms that we need to look further. We do a lot of imaging as it pertains to specific symptoms. So if you're a patient who's had a liver abscess and you come in with fever and abdominal pain, my first guess is that you have another liver abscess, and so we're going to scan your abdomen. So it's really your history is guiding your experience. If you're coughing, you're going to end up with a CT of your chest so that we can see what's going on in the chest. So again, it pertains to specific symptoms and the history of infections. And then, like I said before in my previous talk, frequent physician visits. So it's important to go when you're feeling well so that your physician knows what you look like when you're well. It also is important because you might not feel bad yet. And so it's our job to really find that before you do. If an infection does develop, patients often need IV therapy, and they often need prolonged therapy. So it may be 4 to 6 weeks, even longer. My rule of thumb and what I teach our trainees is that however long you would treat pneumonia in somebody who didn't have CGD, you double it. So if it was, I think they're going to need 6 weeks of IV therapy, then we should be planning for 12. And that's just, again, a rule of thumb. It's very case specific. And then the infection is followed with blood tests, things like the CRP and ESR, drug levels, like Dr. Zerbe alluded to, and then radiography, like CT scans or MRI, to show that the infection is resolving, and that will guide when you can de-escalate therapy. Okay, now I'm going to switch gears and talk a little bit about interferon gamma. So interferon gamma prophylaxis. So the major trial that came out using interferon gamma was one of those rigorous double-blinded placebo-controlled trials where they gave patients either placebo or interferon. And this was a publication published by the International Chronic Granulomatous Disease International Working Group. So it was a group of multiple universities and the NIH who had patients at each site doing the study. And what they were able to show was that the group that was receiving placebo had a significantly increased risk of infection versus those who were on interferon after starting. And so there was a 25% decrease in rate of infection in those who were receiving interferon. The study also tried to investigate the mechanism of action of interferon to figure out why it's working or how it's working. And unfortunately, that has not been determined. So the exact mechanism of how interferon gamma works in patients with CGD is not known, although this data was quite compelling. So they were also able to show that there was no difference in granulomatous complications or the development of colitis or other non-infectious problems in CGD patients, that it didn't help and it didn't hurt, at least in this study. So how is interferon gamma given? So this is a subcutaneous injection. So subcutaneous means that you're going right underneath the surface of the skin, and this is just a little stolen picture from Google. I shouldn't say that as I'm being recorded, but that's okay. So anyways, it's going in at a 45-degree angle, right underneath the surface of the skin. We're not trying to go into muscle, so typically these are much less painful than, say, a shot, like your tetanus shot is going really into the muscle. And is given 3 times a week. So the dosing is based on your body surface area. Your body surface area takes into account your weight and your height, and is determined mathematically. And so if you're a little person, like a baby, your dose is more based on weight because your body surface area is going to be disproportionate. And then if you're closer to an adult or an older person, older teenager, older child, it's based on that BSA, and the dose is determined there. It is, like I said, given subcutaneously 3 times a week is the recommended dosage. So the major complications of interferon gamma are flu-like symptoms, and this is the biggest complaint we hear from patients. It does not happen in everybody. It's a subset of patients, and they will complain of things like headache, maybe low-grade fever, body aches, and chills. And this occurs usually depending on when you receive the dose, maybe night of or next day after receiving the dose. And there's a few things that we can do to alleviate these symptoms. So one is pre-treating with acetaminophen or Tylenol. Another is giving the dose at night. So I do this with some of my children. They get it before bed and they sort of sleep it off. So by the next day they feel all right. The other is reducing the dose. We can reduce it up to about 50%, or sometimes even space the dose, although that's not recommended in the package insert. Some people will space the dose so it's maybe twice a week, 1 week, 3 times a week the next week, or something like that, so an interval of every so many days. So interferon gamma for treatment or for prophylaxis. So there's a lot of dialogue and a lot of discrepancy about how physicians use interferon gamma, and it may be different for all of you even in this room. Interferon gamma is approved for prophylaxis, and that's what it's intended to be used for. However, it can be initiated during acute infection. So we see some patients who have CGD who have never been on interferon gamma, and maybe it's started during a pneumonia or something like that. The side effects of the medication, though, can often muddy the waters with the underlying problem. So for example, if you have pneumonia and I've started interferon gamma and you develop fever, do I know if the fever is from the interferon gamma, or do I know if the fever is because the pneumonia is not being adequately treated? Now, if you're able to make the association adequately, sometimes we can figure that out, but it complicates the picture sometimes. And if it's initiated at infection, it should be continued after treatment of the infection. There's no great evidence that it's doing anything to acutely treat an infection. So it's, like I said, intended to be a prophylactic medication. So not everyone is on interferon gamma, and there's lots of reasons why. Doctors rely heavily on knowing the mechanism of a drug, and so when we don't exactly know why something's working, we get anxious about it. So do patients. And so, but there are a lot of drugs in medicine that are like this too. So I don't want to just focus on interferon. There are a lot of medicines we give people that we don't exactly know why it's doing. Prednisone is a great example. Prednisone is a great immunosuppressant. We know it suppresses the immune system. We know it makes you want to run wild and pack lunches, but it doesn't. We don't really know what it's doing. So that's a great example of another medication. Large natural history studies that have been done in the US and others have not really addressed whether it's beneficial. They haven't looked at interferon versus not interferon and seeing if it's held up. There was one Italian natural history study had 60 patients that didn't show benefit in patients who were receiving interferon and Bactrim and itraconazole versus those who were not receiving it and receiving Bactrim and itraconazole alone. However, that's only one study and is relatively small. There was also a recent US study of 27 patients that showed benefit of what quote unquote, is referred to as triple prophylaxis, or the use of antibiotics, antifungals, and interferon gamma. So the point of this slide is the jury is still out, and there's more than one way to skin a cat, so to speak, and so people do things differently in regards to interferon gamma. And that is all I have.
Thank you, Jen, for the kind introduction. And I would like to thank the Immune Deficiency Foundation for inviting me to this conference and allowing me an opportunity to meet with all of you. This is the first time I am attending this meeting, but I'm already very impressed by the level of questions from the audience. So as Jen said, I've been at Duke for more than 10 years, and I've been involved in the transplant of patients with CGD over the years. And I will, in the next 20-25 minutes, try to give you a brief overview of the role of stem cell transplant in CGD. So you heard from Dr. Leiding and Dr. Zerbe the various clinical manifestations of CGD, so I won't elaborate, but just to kind of give a brief introduction, I will remind you again that CGD is a very rare genetic disease, and it affects approximately 1 in 200 to 1 in 250,000 children, live births. And the main point of the pathology is that it's abnormality in the phagocytic cells. And the common phagocytic cells in the body are neutrophils and monocyte macrophages. And these cells are supposed to kill the bacteria and fungi and some of these other microorganisms by ingesting them, and after ingesting them to kind of cook them with this reactive oxygen metabolites. And because of the defect in the NADPH oxidase proteins, they are unable to do so. So as a result of that, they have characteristic infections, and these are some of the common infections. Dr. Leiding gave you a more comprehensive review of the whole spectrum of infections that you can see. In addition to infection, they can also have inflammation and autoimmune phenomenon, which also Dr. Zerbe gave you a very nice overview of one of the classic manifestations, that is colitis. And again, to review briefly the main causes or associations with CGD, there are at least 5 genes now we know that mutations within which can cause or associated with CGD. The most common one in the North American registries is the GP91 FOX mutation, which is encoded on the X chromosome, and that's why the inheritance is X-linked. This also happens to be one of the more severe types of CGDs. And amongst the autosomal recessive types, the P47 FOX is the more common one. Since we also see patients from communities where consanguinity is more common, and therefore autosomal recessive diseases are more common, in some of these communities, autosomal recessive diseases may be actually more common. And as you saw, with the conservative management, which consists of infection prophylaxis, gamma interferon, and anti-inflammatory treatment with steroids and steroid-sparing agents, the outlook for patients with CGD is much better today than it was several years ago. Which is a very good thing to know. However, there is still a high risk in patients with CGD from the medical point of view. The patients tend to still have infections, and some of them are very life-threatening and at a certain frequency. Also, there is a mortality rate of about 1 to 5% per year in these patients. And there are some studies, this one from UK, which is a representative of a well-resourced country. These are patients who got antibiotic prophylaxis and good supportive care. And in spite of that, you can see the median survival which means 50% of the patients lived up to 30 years. Now, of course, there is a lot of variability in CGD as we are seeing with each subsequent talk. So what the median survival of 30 years means that half the patients live less than 30 years, but the other half can live more than 30 years. Of course, there is a question of morbidity. So patients who live more than 30 years can still have a lot of morbidity. So we have to keep this variability in mind, because as a transplant physician, knowing that transplant has risks, it's really important for me as a transplant physician and the patients to know when to take the risk of transplant. So this variability is something that we need to probe into, and we are all part of a treatment consortium, the Primary Immune Disease Treatment Consortium, or the PIDTC, and we are trying to study just these type of issues to try to predict which patients will have more severe disease. And this study, which you just saw recently in the previous slides from Jen, Leiding. So this is the study from NIH, which is a very good example of an attempt to try to figure out which patient is going to have more severe disease. And as you can see on the left side here, the level of oxidase production in the patient is quite, it appears to be quite predictive of the survival. With low oxidase production or no oxidase production, the survival is much worse than if the oxidase production, at least some oxidase production is present. Now, in the patients in quartile 3 and 4 here, there is some oxidase production. It is still abnormal. That's why the patient has CGD. So that's important to know. And on the right panel, what you can see is that certain genotypes tend to cluster in areas of low oxidase. So for example, the dark blue dots that you see here, those are the patients with GP91 mutation, which is a nonsense type of mutation, and thereby meaning that these patients really make very little or no GP91 protein. So again, the genotype also can help in predicting which patient is going to have very low oxidase and thereby poor outcome. The red dots, on the other hand, are patients belonging to the P47 deficiency, and they tend to, in general, have less severe disease. So you heard a lot about the conservative management, and there is definitely a very big role for conservative management in keeping patients with CGD healthy. But they are not curative. So the only known curative therapies are the cell-based therapies, and I've listed them here as allogeneic and autologous cell-based therapies. So the term allogeneic means when you give cell from somebody else, not yourself. And hematopoietic stem cell transplant is an example of allogeneic cell-based therapy. Here you take the cells from someone else who we think is an appropriate donor, and then you put those cells in yourself, meaning the patient, and then watch them grow and watch them cure the disease. So the allogeneic hematopoietic stem cell transplant is a very established therapy. In fact, the very first allogeneic stem cell transplant was performed by Dr. Robert Good in 1968, and that was for a patient with primary immune deficiency. So we have decades of experience with this type of treatment. One of the fundamental issues when you put somebody else's cells in the patient is that there is a tendency for the donor cells, meaning the cells from outside, to react with you or the patient, and this fundamental reaction causes some manifestations, and those are termed as graft-versus-host disease. It doesn't occur in everybody, and it doesn't really cause very bad disease in everybody, but it is a fundamental characteristic of allogeneic stem cell transplant. And this GVHD is the type of cells in the donor graft that cause GVHD are the immune cells known as the lymphocytes. So when you go to your doctor and they give you a blood count, a CBC with differential, you will see that in the CBC there are white blood cell counts, and these white blood cell count, the neutrophil or the defective cells in CGD are the neutrophils. They are also white blood cells, but the lymphocyte is another big component of the white blood cells, which is what causes the GVHD. The lymphocytes are not inherently defective in CGD, but in any person who gets a transplant, the lymphocytes are going to come with the graft and they can cause graft-versus-host disease. The other type of cell-based therapies are autologous, where you get your own cells back. And typically, autologous therapy doesn't have a role in genetic diseases because you cannot get your own defective cells back. So the only way autologous therapy is relevant in genetic diseases is if you modify your cells. You take out your cells, take them to the lab, correct the defective gene in those cells, and then put them back in your body. So that is the basis for autologous gene-based therapies. The big advantage in autologous cell-based therapies is that because they are your own cells, you don't have any graft-versus-host disease. But these therapies are in the early stages of investigation, and Dr. Malech and his group is at the front line of gene therapy studies, and you're going to hear about gene therapy right after this. Oops. So who should get a transplant? I told you that there are some risks, and I'll be showing you some data about the risks. But who should get a transplant? So the slide from NIH studies about the oxidase level and the genotype predicting bad outcomes is certainly very useful in this regard, and we will keep studying the patient's outcomes and keep learning and keep increasing our confidence in the ability to predict which patient is going to do well and which patient is not going to do well. But there are some things that happen to the patients that are in your face that can help us decide which patient to transplant or not. And the European group, Inborn Errors Working Party, came up with some pragmatic guidelines, which I have listed here. So patients who have infections, for example, more than one life-threatening infection in the past. So let's say one bad episode of Aspergillus pneumonia, or one case of liver abscess, something similar. So any history of life-threatening infection is predictive of severe disease. Similarly, there are patients who have ongoing infection that are not responding well to treatment, or they're refractory to treatment. For example, Aspergillus pneumonia. So I once had a patient who walked into our office with a pectus excavatum, meaning the chest was bulging, and he had low-grade fevers, but he was walking around. And when we did the CT scan, which was on the first slide of my presentation, we saw a huge pneumonia. And then the doctor, then I asked the surgeon to do a biopsy, and when the surgeon looked at the CT scan, he said that this lesion seems to be so vascular that this patient could die on the table. I said that we still need to do the biopsy. So we did the biopsy. Luckily, the patient did all right. But after the biopsy was done in the afternoon, at 5 o'clock, as I was driving, I got a phone call from the lab that the broth of this culture is growing Aspergillus. So within a day. So this kid had such bad Aspergillus infection, and he was walking around with it. So this is the type of patient who, then we treated this patient with 1 year of interferon gamma and multiple antifungal, and then transplanted. And he's doing fine now. But the point is that these are the type of infection that you don't want to, you should try to transplant these patients if possible. And then there are several patients who have, as a result of repeated infections or inflammations, the organs start having problems. The infection and inflammation take a toll on the organs. For example, repeated pneumonias will cause scarring of the lung tissue, and that will lead to abnormal lung function. The patient's lungs start getting scarred and they are not able to get enough oxygen in their body. Repeated colitis and other inflammation need treatment with steroids, and you saw how bad the bones can become with steroids. You can have compression fractures, you can have high risk of fungal infection just from steroid treatment itself. So these are also the patients who are at very high risk of dying, and they need consideration for transplant. And of course, if there is no way of effectively providing medical care if the patient is non-compliant, those are also patients that can be considered for transplant. So, sorry? Yeah?
Earlier you were talking about the mortality rate and life-threatening issues. Why would that be if we're taking the interferon gamma and taking the antibiotics that we're given? Would that not help, and why would another infection go?
So like Dr. Leiding said, that when you give the prophylactic antibiotics, the infection rate goes from 1 per year to 0.15 per year, but that is still, normally you should have a 0 infection rate. And even though the infection rate is going down from once a year to once every 3 years, but that infection that you get after 3 years could be a life-threatening fatal infection. So I think the infections that you get in CGD tend to be very severe as compared to what you would see in a general population. And then interferon gamma, we already saw that the studies, there's limited studies, so we don't know the breadth of its efficacy. We do use it, and we don't seem to have major problems using it. But the bottom line is that there are limitations to what the antibiotic treatment and the interferon can do. So just taking antibiotics and interferon doesn't mean that you may not have these serious problems.
And with the bone transplant, would that be also a reason that another infection growing in? If the bone marrow transplant, if the test was not fully completed and you found out sooner or later after the procedure, after the transplant's been done, that the carrier, the donor, actually had a disease, what happened then?
Right, good question. So, of course, we are very rigorous in selecting the donors, and I'm going to talk about that in a little bit. But so when we select donors for transplant, we either use donors from within the family. If we use donors from within the family, then we, of course, will know who is the carrier and who is not. Again, if it is an X-linked disease, we tend to avoid carriers. But if it is an autosomal recessive disease, a carrier should not matter. The carriers are totally unaffected. Now, as far as unrelated donors, when you register to be a bone marrow donor, there's a lengthy questionnaire that you have to fill out. And if there's any history characteristic of CGD, then you would be excluded. So I think, and besides, CGD is an extremely rare disease. The odds of finding CGD in an unrelated donor is very, very small. And also the unrelated donors who, when they are called to donate, they do have a thorough medical examination, and they have to be cleared by a physician. So if there's any question or doubt about CGD in this patient, they would be excluded as donors. So there is some level of, there's a lot of safety built into the selection of donors. Okay. So now I'm going to spend a few slides highlighting some of the basic aspects of transplant, and these apply to transplants in general. So you've heard a lot about stem cells. You hear about embryonic stem cells, you hear about adult stem cells, mesenchymal stem cells. It's very confusing. So I will just make it very clear that we are not talking about embryonic stem cells. Those are the type of stem cells that has nothing to do with the type of stem cells we are talking about. The type of stem cells we are talking about fall into the category of adult stem cells, because they they are the stem cells that are collected after the baby is born. And within the stem cell category, there can be stem cells in each tissue, but what we are especially interested in stem cells that give rise to the blood elements. So they are called hematopoietic stem cells. So that's what we are talking about. So this schematic here is showing you how from the stem cells, which are at the top part of this diagram, through a multiple orderly steps of multiplication and differentiation, you get all the various blood elements. So the various blood elements are red cells right here, platelets. So the red cells, as you know, are important in carrying oxygen. In CGD, they are absolutely normal. The platelets are cells which help your blood clot. Again, they are completely normal in CGD. What is abnormal in CGD is the white cell, and particularly the neutrophil and the macrophages. So, however, these neutrophils and the macrophages are all derived from the same hematopoietic stem cells. So if you want to fix the problem of CGD, all you need to do is replace this abnormal hematopoietic stem cells with stem cells that are not defective. So in other words, put someone else's stem cells that doesn't have CGD into the patient, and that really is what is meant by stem cell transplant. But it's not as easy as it sounds in real practice. So now, can you take stem cells from anybody in the family or any random person? No, because there has to be something called as HLA matching between the donor and the patient. Now, what does HLA mean? HLA stands for human leukocyte antigen. This is a system of proteins that are produced and are represented on all the cells in the body, and they are classified into two main classes, class 1 and 2. The proteins of class 1 are the important ones for transplant at present are called A, B, and C, whereas the proteins of class 2 that are important right now are DRB1 and DQB1. There are many more proteins that are present in these in the HLA system, but most of them are not relevant because they do not impact the outcomes of transplant significantly. And also, there are some that we just don't know, we have not discovered yet. Now, each patient has these proteins, these A, B, C, D, R, B1, DQB1, so there's 5 sets of proteins. Each patient inherits these 5 sets of proteins from the father as well as the mother. So the entire set of HLA proteins, the A, B, C, D, R, B1, and DQB1 that a patient gets from the mother is called the maternal haplotype, and the same set from the father is called the paternal haplotype. And so each patient or each individual is going to have a total of 10 proteins, 5 from the mother and 5 from the father, that you need to match with whoever is the donor for this cell. And that's why we commonly hear about 10 out of 10 match or 9 out of 10 match. So that terminology comes from these 5 proteins. Now, so that's how you match the individual. Now, from the individual, where do you get the cells from? So the most traditional way, and the way how the field started in the 1960s and 70s, is the bone marrow. We know that the bone marrow in individuals is a rich source of stem cells. The peripheral blood, about 2 decades ago, the peripheral blood was known to have very few stem cells, and so it was not possible to do transplant with peripheral blood stem cells. But with the advent of pheresis technology, we can now run the patient's blood through the machine through repeated cycles and collect plenty of stem cells even from the peripheral blood. So now peripheral blood stem cell transplant is also feasible, even though in pediatrics this is not very popular because the type of stem cells in the peripheral blood cause more reaction, the GVHD that we mentioned earlier. And then the third type of source from which you can get stem cells is umbilical cord blood. This is the blood that is present in the placenta, which is typically thrown away. But about 2 decades ago, it was found that this blood is actually a very rich source of stem cells, and these stem cells are actually biologically very naive, which is an advantage because they cause less graft-versus-host disease. And because of that, partially mismatched transplants are also feasible with this. Now, if you integrate the information from HLA matching and the graft source, then you have a situation where you can have a brother or sister or a relative within the family that is a full match with the patient. In any individual, there's a family, there's a 1 in 4 chance that siblings will be HLA identical to one another. So this is, sometimes you do get lucky and you have such a match. So a bone marrow transplant from a match-related donor is one of the most standard type of transplants, and that's actually the gold standard because the outcomes are the best when you do a bone marrow transplant from a matched-related donor. But majority of the patients who need transplant do not have such a donor. I would say about 20-30% of the patients have such a donor, but with modern families being smaller and also the element of chance, it's often not possible to have such a donor. So then you have to look for alternatives to match-related donor. So you can find a match from amongst the volunteers that have registered to be bone marrow donors. And when you find a 10 out of 10 match from within the volunteers from the registry, that is called a matched unrelated donor, or MUD, or MUD in our lingo. There is a registry of about 20 to 30 million donors. It's located in Minnesota. It's called the National Marrow Donor Program, and that is our North American or American registry, and it has ties with registries throughout the world, and whenever we are searching for a donor, that's the registry that we use. And there are several patients who have neither a match-related donor nor an unrelated donor, and for such patients, partially mismatched umbilical cord blood is a viable option, and I will show you some data later on. There are also situations where parents, being half matches to the children, could be considered as donors for transplant. There is not enough data of use of such donors, especially in CGD, but this is an area of active research, and maybe in the next few years we will see a lot more data using this type of donor. So now that we have identified the donors, now we need to figure out how to proceed, how to prepare the patient for transplant. Because if you just took bone marrow from the individual and put it in the patient without any preparation, there will be 100% chance of rejection. So the new cells will get outright rejected because of the patient's immunity. So you definitely need to prepare the patient for transplant. And the medications and the radiation or whatever treatment modality we use to prepare the patient for the transplant, that is what is called as conditioning regimen. So the goals of the conditioning regimen are twofold. One is called myeloablation, and the other one is called immunoablation or immunosuppression. And the myeloablation basically means killing of the stem cells and the progenitor cells in the bone marrow, and in order to create space for the new donor cells. And if the patient had a cancer, then an additional goal for myeloablation would be to kill cancer cells, but this is not relevant to us. The treatment modalities that are best suited for myeloablation are radiation. It's called total body irradiation because the whole body is subjected to the radiation. And the radiation is a good way of killing the bone marrow cells. It's a very effective way of killing bone marrow cells. There are also chemotherapeutic agents which are considered equivalent to radiation, such as busulfan and melphalan, which can be used to kill bone marrow cells, stem cells. The second goal of conditioning regimen is to kill the immune cells, so as to prevent rejection of the graft. And for this purpose, radiation again doubles up as immunosuppressive agent. There are some chemotherapeutic agents such as fludarabine and cyclophosphamide which are better suited for killing immune cells than busulfan. Also, there are antibody treatments such as anti-thymocyte globulin and alemtuzumab, also commonly known as Campath, which target the lymphocytes and are important in contributing to prevention of rejection. Now, as opposed to the chemotherapy and the radiation where the effect is strong but it is very fleeting, the chemotherapy is out of your body within hours, radiation after killing the cells is gone within instants. As compared to that, the antibody circulate in the body for a longer period of time, 2 to 3 weeks or so. So even after transplant, they hang around in the body to some level, and after transplant, when the donor cells, the immune cells in the donor are growing and trying to create graft-versus-host disease, some of them can be killed by these antibodies. So the antibody treatment can also double up as graft-versus-host disease preventive agents. So in addition to that, there are other medications that are important in controlling graft-versus-host disease, which actually form the backbone of controlling graft-versus-host disease. And they are medicines known as cyclosporin or tacrolimus, mycophenolate, methotrexate, and steroids. So we do need to give these medicines to patients after transplant for several months until the donor cells get used to the patient's body. Eventually, patients do get off all the medications and they can have a normal life. So the conditioning regimens, there are various types of conditioning regimens. If you Google conditioning regimens, you will find lots of different types of regimens. So I just want to explain what all these nomenclature means. So depending, so like I said, we need both immunoablation and myeloablation. We need certain amount of these. So if you have, for example, cancer, you need a maximum amount of myelosuppression and maximum amount of immunoablation. So those kind of regimens are going to be in the upper right corner here. And they are mostly based on radiation and high-dose busulfan. If you use regimens that have very minimal amount of myelosuppression, very minimal amount of immunosuppression, those are the regimens that hardly do anything to the patient. Unfortunately, they're not very effective in treating children with non-malignant diseases. So then there are lots of regimens in between these two extremes, and they are the ones that are called as reduced toxicity regimens. And there is a lot of interest in developing reduced toxicity regimens because they are effective and yet they have the potential to decrease the toxicity of myeloablative conditioning. So this is just to give you an idea of the common regimens that we use. So if you read something about it, it may make more sense to you. So the most common myeloablative regimens that we use in cancer, leukemia treatment are radiation-based. A high dose of TBI, 12 to 13 gray, is given to the patient along with immunosuppressive medication like cyclophosphamide with or without some type of antibody treatment. In children with non-malignant diseases, sometimes we avoid radiation, and in fact our goal is to avoid radiation, so we use chemotherapy. The dose of chemotherapy, busulfan for myeloablative regimen is about 14 to 16 milligram per kilo. Now, in reduced intensity regimens, the dose intensity of either radiation or busulfan is significantly reduced, and it is still possible to get the donor cells to stay in the patient, meaning it's still possible to avoid rejection because of this medicine called fludarabine and and antibody treatment. So these are highly immunosuppressive medications, and they prevent rejection in spite of decreasing the dose of the myeloablative medications. And this just shows you that after the patient gets chemotherapy, the bone marrow stem cells get killed, and because of that, you see there is the blood counts drop, the neutrophil counts drop. And this is an example of what happens to the white count after getting chemotherapy. There is a decrease in the white count, we call that neutropenia, and after some time, as the cells start growing, it's a little bit like planting a seed. When you plant the seed, you first have to prepare the ground. That is like the conditioning regimen. After preparing the ground, you plant the seed. That is like the stem cell transplant. And after planting the stem cells, after planting the seed, you have to give fertilizer and things like that. So in stem cell transplant, after putting the cells in, we have to give nutrition, we have to give growth factors called GCSF, and we have to control the weeds, meaning the infection. So we have to give antibiotics, antifungal agents, antiviral agents. So, and just like after a few days, the seeds start sprouting and you start seeing leaves and things like that. So just like that, after some days, we will start seeing an increase in the neutrophil count. And at some point, when the neutrophil count is more than 500, we say that we have success. We call that as engraftment in our technical term. This is a typical profile of neutrophil recovery after myeloablative transplant. When you use reduced intensity conditioning, depending on how severe the reduced intensity is, you will see some sort of profile like this. So the bottom line is that the neutropenia after reduced intensity conditioning may not be as profound as you see after myeloablative regimen, and it may not be as prolonged as you would see with a myeloablative regimen. And because infections tend to occur when you have neutropenia, giving reduced intensity regimen has the potential to decrease the risk of that period of infection risk. So what are the various complications? I've been telling you again and again transplant is risky, and that's why we need to think hard about whom to transplant. So now I'm going to give you a little bit of information about complications. And I must warn you that the slides that I have chosen are some of the more severe cases. And fortunately, not everybody gets these complications. In fact, the vast majority of the patients nowadays do not get these bad complications. But I will review these complications now. So graft-versus-host disease, we said this is a fundamental problem with allogeneic transplant. Whether there is a clinical disease or not, some level of graft-versus activity is occurring all the time after any allogeneic transplant. And sometimes it gets to a point where you start seeing manifestations such as skin rash and diarrhea and things like that. So that is called as a graft-versus-host disease. So this is a picture which shows that there are two types of graft-versus-host disease, acute graft-versus-host disease and a chronic graft-versus-host disease. In the old days, we used to use 100-day as a cutoff between acute and chronic graft-versus-host disease. In other words, any manifestations that were attributed to graft-versus-host disease before 100 days, we would call that as acute graft-versus-host disease, and anything after 100 days, we would call chronic graft-versus-host disease. But over time, we have learned that acute graft-versus-host disease and chronic graft-versus-host are distinct entities, and they have their own clinical and pathological features. Typically, acute graft-versus-host disease tends to evolve into chronic graft-versus-host disease, but sometimes you can have chronic graft-versus-host disease arise without any preceding acute graft-versus-host disease. So, and a lot of times there is an overlap. Patient could have signs of both acute and chronic graft-versus-host disease. This is just an example of acute skin graft-versus-host disease, a very severe type, what we call as erythroderma. The typical things that we see with graft-versus-host disease are skin rashes, like you saw in the picture above. That patient probably has grade stage 4 type of skin rash. But you can also see involvement of the liver, which we measure from the bilirubin levels in the blood. And gut involvement is also very common with acute graft-versus-host disease. And depending on how much diarrhea the patient has, we will then quantify the level of graft-versus-host disease. So based on all these signs and symptoms, then we grade the graft-versus-host disease into 4 categories, 1, 2, 3, and 4. Again, the higher number is the worst number. Grade 1 and 2 graft-versus-host disease are very common, and they don't really impact the long-term outcome of transplant. Patients tend to recover from that without too much treatment. But the grade 3 and 4, or the higher grades of GVHD, are the ones which have the potential to cause long-term problems. Again, it doesn't mean that they can never be treated, but that is the type of GVHD that doctors worry about. And then chronic graft-versus-host disease is a different syndrome. The rashes look different. It's more, it looks more like an autoimmune or a rheumatologic condition in many cases. You can see here the skin involvement of chronic graft-versus-host disease is not like an angry red rash, but rather looks more like somebody with arthritis, where there is fibrosis and there's limitation of joint movement, and there is scarring of the skin and things like that. The next complication that we worry about after transplant is infection. Because we have given chemotherapy and the bone marrow cells have been killed, and the cells in the bone marrow that fight with infection are neutrophils and the lymphocytes, and they've both been killed. So you have a risk for infection from not only bacteria and fungi, but also from viruses. The chemotherapy drugs are very strong drugs, and while the goal is to kill the cells of the bone marrow, but a lot of times they end up damaging tissues in other places, such as lungs, liver, and also sometimes they can cause problems in the brain. So these are the more serious organ toxicities that we, like I said, we don't fortunately see in most of the patients. What we see in most of the patients are mouth sores, diarrhea, what we call as mucositis, hair loss. So these are the more common things that we see as in terms of organ toxicity. So far, whatever I said are all acute effects within the first few months after transplant, but these drugs are very strong, and they can sometimes leave long-lasting effects on the patient, and often they are involvement of the endocrine system. So the gonadal toxicity is a very well-known problem with chemotherapy or radiation, but there are other endocrine problems such as growth problems. There's a very small increase, but a real increase in the risk of skin cancers and soft tissue cancers. And all these risks are much higher with radiation as compared to chemotherapy. And within chemotherapy, the complication late effects are likely to be less with reduced toxicity chemotherapy than with myeloablative chemotherapy. So I think knowing how transplant works in general, and knowing the basics of transplant. Now I wanted to show you a few slides about how this works in the setting of CGD. So after you have understood the risks of transplant and made up your mind to proceed with transplant, then the next step is to make sure that the patient is actually healthy enough to go through transplant. And for that reason, we do what is called as pre-transplant workup. So we're really doing lots of studies for a variety of reasons. You absolutely do not want to transplant patient for a wrong diagnosis. So we always make a lot of effort to confirm the diagnosis, characterize the disease. Even the donor, we try as much as possible to rule out any risks or disease. We make sure that the patient's organ functions are satisfactory, and if they are not, then we have to make plans to address that. For example, if the patient has a lot of infections, then we have to make sure that we evaluate the infection, do biopsies, bronchoalveolar lavage, etc. If the patient has active infection that is not responding, sometimes we do treatments such as granulocyte transfusions to get them under control. And we also want to make sure that patients have adequate nutritional status, because if the patient's nutritional status is poor, they will not be able to handle chemotherapy and their recovery will really be affected. So this is a schematic I will briefly go over. So we talked about conditioning, where we give either chemotherapy or radiation. The type of conditioning, myeloablative or reduced toxicity, has to be determined by the physician. The patient's condition tends to influence this decision making. For example, if the patient is very sick, has poor organ function, then more than likely I would use reduced toxicity conditioning. If the patient is young with minimal symptoms, then I might consider myeloablative conditioning. So after getting the conditioning, the patient is then given the stem cell infusion, and we talked about the various graft sources, and I will show you some slides about outcomes with different graft sources. With this conditioning, then the bone marrow cells get killed and the blood counts drop, and that is called the phase of aplasia. During this phase also you can see mucositis and some of the other acute organ toxicities such as liver, veno-occlusive disease, etc. There's always a high risk of infection during this phase as well. So after this phase, then the cells start growing, and we talked about how the neutrophils recover. We call this as engraftment. When the cells grow, they can tend to cause GVHD, which we need to control with variety of approaches. And when the cells grow, then we are always very curious, and it's very important to establish whose cells are growing, and that test is known as chimerism. What we want is we want donor chimerism. Ideally, we want full donor chimerism. With myeloablative treatment, there's a higher likelihood of getting full myeloid chimerism, but there are higher risks. So when you use reduced intensity conditioning, our goal is to get a good donor chimerism, if not full donor chimerism. And a lot of times we can have mixed donor chimerism, which can remain stable over time and still cure the disease. And then with time, the cells continue to grow, and the whole immune system is reconstituted from the donor cells, and then also the basic defect, which in this case is CGD, gets cured. We see control of colitis, we see control of infections, and we see prolonging of life expectancy. And during this phase, then we also have to watch for if these donor cells are causing any graft-versus-host disease, and if so, have to treat them appropriately. So here I'm going to, in the last few minutes, I'm going to show some real data of transplant. I told you earlier that match-related donor is the gold standard. And so historically, the transplants in CGD, and in fact most of the pediatric non-malignant diseases, have been carried out from matched sibling donor. And these type of transplants result in about 90% disease-free survival. And these three studies that you see here are some of the larger studies using match-related donor, and you can see that the survival rate is good. But also what you notice is that a lot of the patients here did get match-unrelated donor and still had good survival. So as long as there is a matched donor, related or unrelated, the survival tends to be good. It's just that we have a lot more data with matched sibling as compared to match-unrelated donor until recently. So this paper by Dr. Gungor was published in 2013, where he used unrelated donors as well as related donors, but predominantly unrelated donors in about 56 patients. And what he did was he decreased the intensity of busulfan. So he used a reduced intensity busulfan-based conditioning, and you can see that the survival was close to 91%. So very similar to what we have gotten historically. But one thing that was found in this study is that because the exposure of busulfan was decreased, it was very critical to monitor the exact precise exposure that the patient got. Because as you can see here, the patients who got slightly lower than anticipated or targeted exposure to busulfan did have problems with graft failure. So the point here is that reduced intensity conditioning can work. Reduced intensity conditioning should be the way of the future, but there are some caveats, and as we do more and more, we are going to learn and fine-tune this approach. And then there is another promising agent. It's called triosulfan. And there was a study published in 2016 from Europe with the use of triosulfan. And what they found was that in 70 patients, which is a large number of patients, the outcome was 81% overall event-free survival, meaning cure rate was 81%. One thing to note is that these patients, a lot of these, in fact, majority of these patients were very, very high-risk disease with lots of infections and inflammatory complications. So for that group of patients, a reduced intensity regimen giving rise to this type of outcome is considered very good. One important point here is that 8 patients had graft failure. Out of those 8 patients, 7 patients could be rescued with either giving extra cells from the donor or with a second transplant. So if you look at the overall survival in the long term, it was still about 90%. So to get these type of results in a population of patients that is very sick, I think is really encouraging news for the CGD community. And then there are a lot of patients who need transplant really badly, and they don't have either a match-related or a match-unrelated voluntary donor. So in these patients, cord blood becomes an attractive option, because like I said earlier, with cord blood you can do mismatched transplant, and when you allow for 1 or 2 mismatch, suddenly the number of donors that are suitable increases, and virtually everybody is able to get 1 or 2 antigen mismatch cord blood donor. So we published the first 2 cases that we did with cord blood transplant a long time ago, and we used myeloablative regimen, and in spite of that, in spite of using Bucy in these first 2 patients with cord blood, they had graft failure, and we had to do second transplants. Eventually both these patients did well, and they're more than 13 or 14 years post-transplant now. But because of this reason, when we continued to do cord blood transplants, we were reluctant to reduce the intensity of the conditioning regimen. So subsequently, we have been using a regimen of fludarabine, busulfan, and Cytoxan for all these patients. And when we published our results in 2012, we had done cord blood transplant for 7 patients. All of them were alive. And the most recent data as of last month, we have performed 14 cord blood transplants with a 93% cure rate. And these patients have very good quality of life as well. So clearly, transplant has a great impact on survival based on the transplant data that I just showed you. But I want to show you a couple of slides to see what is really happening to these patients. So this is the patient I talked to you who first presented to me with a chest bulge, and who we treated for many months with antifungal treatment. So we did a transplant for this patient under the cover of granulocyte transfusions, and he is now 14 years post-transplant. And this is a CT scan that was done about 5 years after transplant, which shows that he has not had any recurrence of infection. So clearly, it is very effective in changing the immune function of these patients. And this is a picture that I took from one of the papers written by a doctor expert from Europe. And here he has shown that the colitis manifestations also get better after transplant. So clearly the infectious complications as well as the non-infectious complications have the potential to benefit from transplant. And then Dr. Leiding showed you some data from the British study where they compared patients who got transplant with the ones who did not get transplant. And in this slide taken from that paper, you can clearly see that the patients who got transplant had a significant improvement in their growth. Just for those of you who cannot make sense of these numbers, the standard deviation negative 1.15 is worse than negative 0.29. Basically, what it means is that the patient in the non-transplant group had much lower growth as compared to the normals. And the p-value, it determines the significance of these findings. And then the same group also studied the health-related quality of life and also showed that the health-related quality of life was much better in the patients who got transplanted compared to the ones that did not get transplanted. So in conclusion, allogeneic transplant is an effective therapy for patients with CGD. It helps in improving the survival as well as it helps in improving the quality of life. The newer regimens promise to decrease the risk of transplant, and that's very exciting. Match-related donor transplants are the gold standard for treatment, but when they're not available, alternative donors such as match-unrelated donors as well as unrelated cord blood are quite feasible. And there's also more interest now in haploidentical donors. So in a few years, hopefully we'll have something to talk about that for CGD as well. So with that, I would like to thank you all for the attention.
So my talk is last here, and we don't want to take too much time from your question period. So I may truncate my talk a little bit, but my talk has the potential to give you a headache because what I'm going to try to do is to give you some. Everybody talks about gene therapy, and it's an exciting area, but most people don't really know from day to day what it is and how it works and where we are in this process. We've been keep in mind that people have been trying to make gene therapy work since about the early 1990s, and really the first successful gene therapy, that is gene therapy that actually benefited patients, occurred around 2000, and that was in a special group of patients, the ones they're talking about over in this room, patients with certain kinds of severe combined immune deficiency. And one of the reasons it worked in those kinds of diseases is that you didn't need to do very well. You could get just a little bit of correction of stem cells, and then there was a huge selective advantage to the outgrowth of lymphocytes that were corrected in those kinds of diseases. CGD is much more along the lines of some other kinds of blood disorders where correcting the abnormality doesn't increase the survival of the cells. It may increase the survival of the patient, but not of the cells. So there's no cheating, there's no selective advantage. The only way you're going to get the gene therapy to work to correct CGD and Wiskott-Aldrich, which is what they're talking about next door over there, and some other diseases, is to do really, really efficient correction of the cells and to get really, really high levels of engraftment of those corrected cells to make it work. So I'm going to avoid talking about the things that didn't work in CGD, and I'm going to focus on some new things, because we've finally reached the era where the efficiencies of what we can do are finally approaching the place where it can really apply to CGD. And I'm going to talk about a new study. You've heard enough about the different kinds of CGD, but just for purposes of discussing today, let's see, is there a mouse here? Or just, oh, there we are, okay. We're mostly going to talk about GP91, but keep in mind that all of us still are working very hard to develop gene therapy for the other forms of CGD. We're not leaving any of the rest of you behind, trust me. And let's see, okay. And then I'm gonna skip this because this is just tells you how this works, which you've seen in many cases. These cells all come together, and the various subunits come together and create the active enzyme, which then makes superoxide and hydrogen peroxide and so on. And so there's three important things that I want to talk about as it relates to gene therapy. The one I've already talked about, which is that there's no selective or growth or survival advantage. So we've got to be really efficient. So we had to be able to develop the gene therapy tools that became very efficient before we finally are reaching a place where we can do beneficial gene therapy for CGD. The other thing I want to remind you of, what you heard about today, which is that female carriers of X-linked CGD, studies of them tell us a lot. So Dr. Zerbe gave you a whole talk about this, so I won't repeat it, except to remind you that if we don't reach 10% of all cells circulating corrected, we're not doing a very good job. Carriers who are below 10% are at risk of infection. It doesn't mean that if we got 10% that we weren't beneficial, but we're certainly not going to cure CGD by just getting to 10%. 10 and 20, well, probably okay. But really the goal we would like to reach is we'd like to routinely correct CGD patients so they're at least 20% of their circulating cells are corrected to get towards something that I hate to use the cure word because that's a loaded thing, but to really provide clinical benefit. But I will remind you, as I'm saying, that at every level that we increase the oxidase activity, that is, that we make cells produce hydrogen peroxide, we're probably providing some benefit. So there's both some goals we need to reach, but every step we can get toward that goal provides some benefit. So there were some older trials using vectors that were the only vectors we had. They were viruses that originally derived from mice. Those vectors in mice cause cancer in mice. And even though we manipulated them, and when I say we, I mean the whole community, and got them to a place where we thought they were useful, in fact, they had two problems. One is, in the studies above here, they caused myelodysplasia and other problems, cancer-like things. And in the studies we did, we didn't cause cancer at the NIH, but we didn't do very well. That is, patients got early high levels of marking, but that quickly went down because these vectors just weren't capable of efficiently targeting the true long-term repopulating stem cells. And this is an example of one of our patients who went through our study, who even at 7 years had a very small number of cells. But I was telling you, gee, I would like to get 10% at the very least, and certainly 20%. Well, this is 0.5%. And this patient benefited from this. He had a decreased rate of infection, but it was nowhere near a cure of CGD. So the vectors that we had just didn't do the job. So Adrian Thrasher and Manuel Gretz from Europe developed a new kind of lentivector, and I'll explain what that is, with a promoter that had some safety features that we were all very excited about. And we actually, they did the hard work, but we actually, in this paper, which describes the vector, we did in fact help them qualify that vector. And I'm just going to take a minute or so just to tell you what is a lentivector. So a lentivector is different from these mouse vectors. Again, this is part of giving you a headache. This is derived from the human immunodeficiency virus. This is the same virus that causes AIDS. So you say, wow, why do we want to work with that? Well, it turns out that the AIDS virus doesn't cause cancer. It causes other problems, but it doesn't itself cause cancer. It reduces immunity in the patients who get AIDS so they can get cancers, but the virus itself intrinsically doesn't cause cancer. And it has to do with where it tends to choose to insert itself in the genome. The mouse kind of virus tries to find places that are places in the genome that are called activators. And those activators, when the mouse virus lands in the genome, intrinsically tends to cause activation of nearby genes, including cancer genes. And that's how it causes cancer. The HIV virus doesn't go to those places. It chooses other places in the genome, and so has an intrinsic, safer pattern of where it goes into the genome. But on top of that, this group, Dull et al., working from the Salk Institute in developing this first version of lentivector, and the word lentivector comes from lentivirus, which is just a scientific term for the group of viruses that the HIV virus belongs to. And so you've got all these different genes in here. And what they did was to strip out all the genes, the envelope gene, TAT, REV, NEF, VIV, and then they even took out the GAG and PRO and POL and all of that, and they ended up with something that just has the elements necessary for the virus to insert in the genome, not to do anything else. But how do you take this thing, which is naked of almost everything else, and package it? So you have to take this GAG and POL, which are the how should I put it, the envelope and other pieces of the virus that you need, and they put it in a different plasmid. And then they needed this REV thing, and they put it in another plasmid. And then they pulled an envelope from an entirely different virus that doesn't cause much disease. And they put them all in separate things. They changed the genome so that these things couldn't recombine. In other words, anything that would normally overlap no longer overlap. And so now you have to take these 4 vectors. So now you take a gene that you want to fix things with. Let me see. I need to get the arrow again. So now you've got this place here where you supply the promoter and you supply the transgene. Well, the transgene in this case for X-linked CGD is the GP91 protein coding sequence, and even that's changed a little bit. It's optimized. It makes the same amino acids, but it's changed so that it can't recombine with other things as well. And the promoter that was chosen was not a virus promoter, but rather human promoters that normally make some neutrophil proteins. So it's a natural human promoter. A promoter is something that helps to make the RNA, which then makes the protein that you need. And this 4-vector system, so you have to take all 4 of these and put them at the same time in a cell in the laboratory. That packages this thing up inside the virus package, so it looks like a virus, but it has no elements, so it can't reproduce. So what you get out of the packaging system is only a virus that has that's a one-way street. It can infect, it can deliver its package into the genome, but it can't come out again as a virus. And it's been stripped of all these other things. And I could give a very long talk, which I won't, and a boring one, for all kinds of safety features that were done on this to show it doesn't activate nearby genes when it goes in the genome. It goes in places that are different than this murine retroviral type vector, and it doesn't have any of these other elements. It doesn't bring these other elements into the cell. So, this is a study that's actually brought together people literally all over the world. We've got a group in London. We've got a group in Germany. We've got a group in Paris. and we've got 3 centers here in the U.S., and we've been working as well with the Genethon group, which actually is their precursor they're like the Muscular Dystrophy Association of France, but now they've gotten deeply involved in other rare disorders, including immune deficiencies, and so we've brought them into it as well. So this really is an absolutely international study. It's the only ongoing study for CGD that's recruiting in the world, and it's still very new. And just to, I'm not reading all the names of people, but you can see that there's a whole group of people in a lot of different studies. And this is the protocol schema. Basically what we do is that we collect stem cells from the patients. We then condition the patient. And you might say, well, why do we need some chemotherapy? We need some chemotherapy because we have to make that room in the marrow so that there's a place for these corrected cells to go back into the marrow. If you don't do that, even though it's your own cells, you'll get a very low rate of cells getting back into the marrow. And what happens is the cells are taken, they're put in a culture system, the virus is added twice, and they're only in culture for about 3 days. They're washed up, the patient has been conditioned, and now you give the patient the cells, you cross all your fingers and toes, and hope something good happens in terms of the patient, in terms of the cells having now expressing the genes that we hope to express, that the cells mature and graft in the patient, and that they mature. So the first young adult was treated in Boston Children's Hospital in December 2015, doing well at 18 months. Second patient was treated at the NIH, and that's about 1.5 years out. Third patient was treated in March 2017 and as well at 1.5 months. Now the FDA and other agencies asked that we separate this out that much in time to see that we weren't going to have problems, and now we're at a place where we're going to be treating more patients. In fact, as I speak, a second patient at NIH will receive his cells tomorrow. So that'll be the 4th patient in the U.S. There have been 2 patients treated in London that have done well, and a patient treated in Paris. What I'm going to do is, to keep this relatively short, I'm just going to show you what's happened to the patient treated at NIH, and the same relatively good things have happened to all the other patients that have been treated so far. So this is sort of, I'm not showing you the best. In fact, I think one of the patients in London has a little higher marking than even this patient. So I'm not picking the best, I'm just picking the patient I know the best. So this was an 18-year-old who had recurrent pneumonias on long-term antifungals and other things. We're very carefully monitoring the busulfan dose. This is a relatively high dose. It's not ablative, but it's sort of subablative. From the lecture you just heard, this would not be called non-myeloablative, but neither would it be absolutely an ablative dose. But we needed high levels to get really good engraftment of the cells that we're fixing. There was a good collection. We had lots of cells. It looked like the marking in the test tube was really good, about somewhere close to 50% of cells. But keep in mind, in the test tube, we like to see high levels of marking, but it's always harder to get the true stem cells to accept the virus and get fixed. So it's always a little lower. And then on top of that, we're not replacing all of the patient's cells. So there's you're getting a little cut and then another cut. Sort of like everybody takes their cut, and you get what you finally get as your profit is a little less than what seems to be what you'd like to have. And there were no adverse events. There were no problems except that drop in circulating cells, which then came back up again very quickly. And in fact, the patient went home at day 20 after all of this. And he remains clinically well at 10 months out. actually has had no CGD infections. That doesn't absolutely prove anything because, as you know, CGD patients, their frequency of infection, you can go a year or 2 or 3 without a problem. Doesn't mean everything's fine. So really what I need to talk to you about is, so this is not him. This is just the DHR test. And this would be the ideal. That is a normal, to get 99% of your cells oxidase normal. But in fact, what we've gotten is about in the range of 26 to 30%. And we've done it again more recently now, and it's still sitting there at 26, 28%. That is significantly above our 20% goal. So that looks very good. The marking, meaning we look at the vector marking in the cells, and that sort of matches what we're seeing in the I don't want to go into the fine detail here because that's not the critical issue, but that we're able to measure how many cells have the vector in it, and that also looks very good. And so what we're concluding from this early assessment is that in the whole group of patients, every patient has had is long-term marked at 20 to 40%, and seems to be stable at 9 to 18 months. And now the study's opening up a bit more widely so we can do more patients. But the whole study in the U.S., at least this first phase, is only 10 patients. And we need to watch people for a while. There's a company involved now that's very interested in developing this, and we're hoping that if this goes as well as it seems to be and holds up, that this is going to be a game changer, I think, for the CGD community. And but there's exciting things going on as well. Next door, there's going to be a number of presentations about an absolutely identical kind of approach for Wiskott-Aldrich syndrome with equally good data coming out of that study. I'm going to talk tomorrow about some about some studies of gene therapy for X-linked SCID in older patients, and there's going to be some presentations about this in infants with SCID, also equally exciting. So, we're really reaching an era of clinically beneficial gene therapy. So, what's in the future? So this uses virus vectors. This looks pretty good. One of the things you probably noticed is that not all cells are 100% equal to the DHR of a normal cell. So one of the things we'd like to do is it would be nice to get every cell have the normal amount of superoxide produced. So it's not perfect, but it's pretty exciting. So I'm going to talk to you a little bit. Everybody reads in the papers about CRISPR and zinc fingers and this and that, and I'm just going to spend a few minutes to try to give you a taste for what I think is the future of a gene therapy coming up that may or may not replace virus based gene therapy. But basically what I'm going to talk to you about are some studies we've done in the laboratory in which we've used CRISPR to actually repair a particular mutation in CGD. So if you just repair the mutation and you're all done, what you have is an absolutely normal genome. You don't have virus inserts in there and so on. You've got an absolutely normal genome. Well, that, obviously that's the holy grail, to just take somebody's stem cells and fix them all. So it's just like a normal person's. We're not there yet, but I'll just show you. So, so one of the problems, of course, is that if you're talking about a disease like sickle cell anemia, every patient has the same mutation. So my colleagues who are trying to fix sickle cell disease have it a little bit easier. I won't say it's easy, or they would already be there, and that they've got to idealize the fix for one mutation. Well, here's the GP91, and it's true of some of the other genes as well. You get mutations everywhere. So there's a couple approaches we can take, and I don't have time today to talk about how one might use CRISPR to get one size fits all. One way of doing that is is to use what we call cDNAs. That is to make a cut near the front of the gene and use a copy DNA and just kind of replace the whole gene downstream. But again, there's a certain, I don't know, beauty in trying to fix a specific mutation and make it just like normal. Yes, you had a quick question.
Oh yeah, I was just wondering when you were speaking before if the virus is actually, inserting the entire, you want to talk gene somewhere else.
Yeah.
Not cutting and taking that out and putting the new piece in.
No. So the virus works differently. The virus isn't repairing. The virus is just adding something on the side.
We just add it somewhere else.
It just, in fact, it's adding it in different cells in different places all over the genome. So it works. So I'm happy. But if you're an artist, it's not artistic. So what is CRISPR? As I say, you read about it in a newspaper. Everybody and his uncle is an aunt are talking about CRISPR, and lots of people don't know what CRISPR is. What CRISPR is actually one of several kinds of gene repair tools, but it's the one that's a lot in the news, and the reason it's appealing to scientists developing gene therapy is that it's actually fairly easy to use and apply to different things. It was first discovered as a bacterial protein, and it's part of the bacteria's immune system. So we're actually talking about the bacteria's immune system and borrowing a piece of it and now trying to use it for gene therapy. And what it did in the bacteria was, if the bacteria gets so you think of bacteria as disease itself, but in fact, bacteria get infected with things called phages, which are viruses that infect bacteria, and it's a big war down there in the sewers between the bacteria and their phages, and the bacteria have developed an immune system in which it samples a little piece of the bacteriophage, takes its DNA, and uses this CRISPR to create something that then makes an RNA that matches that fights the virus. And so what's happened is that the scientists who are almost certainly going to get Nobel Prizes for this discovered this and said, wait, we can use this to target places in the genome in human cells and other mammalian cells. And what it is it's a little easier if I just walk over here and just talk loud. Basically, it doesn't matter what the protein looks like, so it's represented here by a blob. And that's the CRISPR. And the CRISPR-Cas9 has the ability to cut DNA, but it needs a guide. And if you give it a guide of RNA that matches someplace in the genome, and there are some rules, there are always rules. The rules is it can't do it everywhere in the genome. It's got to match a certain sequence that we call a PAM site. So if you've got a PAM site, so PAM sites occur maybe every 50 or 60 amino base pairs. So there's a lot of choices, but we need better tools so we can do it anywhere we want. So if you have a PAM site and then you match that RNA that you give the Cas9, it will go to that site in the genome and at an efficient rate make a cut. And where it makes a cut is about the third base pair here. So as I said, there's a lot of rules, and people have now developed computer programs so you figure out what's a good site, what's not a good site, and so on. So we happened to notice that there was a particular mutation. So in that earlier slide, I showed you a very large number of mutations that occur in in the GP91, which is X-linked CGD. But it turns out there is a slight hotspot. 6% of all X-linked CGD patients have a mutation specifically at one site. So we said, gee, would this be a good site to try to do our practicing on? And it turned out that there's a good PAM site in just the right place. And we went ahead and I'm going to actually go forward and then backward on here so I can show you. So what we did was make a whole bunch of guides. And we tried to see which guides work and which guides don't. And again, these are scientific slides, so as not to give you a headache, I'm just going to I'm going to use the slides, but talk through it. So first, what we did was to sort of inspect the sequence, and then come up with a bunch of guides near the sequence. And it turned out, just by chance alone, that using this technology that we used to try to find which guides cut, we found that a particular guide made the Cas9 cut really efficient. That's what this little band is here. And it turned out that it was in a, just by chance alone, was in a very convenient site. It turned out that if the mutation's right here, that the guide encompassed the mutation that was so efficient. It cuts right here, and it only cut if the mutation was there, which is unusual. It doesn't cut the wild type. So if you can repair it, then it won't cut again. As I said, this is all just serendipitous that it worked out to be a good site for this, and that it cut the mutation, but not the wild type. So why do we want to cut? That sounds like we're trying to destroy the site. It turns out that cells have very efficient repair machinery, and it will try to paste together any cut you make. And mostly it pastes it badly. It's like kind of like a 5-year-old with a scissors and tape. It doesn't repair it well. But if you also, at the same time that you drop the CRISPR into the cell, you get a piece of DNA that matches the site almost, except for one fix. The cell will choose to try to grab that as a how should I put it, a Band-Aid, a ruler, or something to follow. And it's pretty efficient at that. Unfortunately, not as efficient as the 5-year-old with the tape and the scissors, but it's pretty efficient. And again, we lucked out because it turned out that the piece of repair DNA that we provided it also was very efficient. And you might say, well, how do we get it into the cells? And for that, I'll go backwards a little. And we've got collaborators at this company called Maxite who have invented this machine that basically electrocutes cells. Again, you might say, well, I don't want to electrocute cells. That's not so good. But it turns out if you do it very gently, you make little holes in the cell that are temporary, and anything in the fluid around it will flow into the cell. So we put the Casper, the guide, and the repair thing all in the fluid around the cells. We run it through this machine, and normally in the lab, this kind of what's called electroporation. I think if we called it electrocution, it wouldn't sound as good. But we called it electroporation. It makes pores. But this machine actually has been used for other things and can be scaled up to full clinical scale. So it works at small scale, but it works also at a scale that we could actually bring this to the clinic if we got this efficient enough. And so, again, I'm not going to bore you with the scientific details, but we actually did a whole lot more work on this. We had to optimize the poration. We had to optimize what media the cells were in. We had to optimize how long. Did we make a shorter guide RNA or a longer one? Did we want to use double-stranded or single-stranded oligonucleotide, which is a piece of DNA? Did we want to modify it to make it less breakdown in the cell, but that made it more toxic to cells, so we had to sort of balance one against the other. And when we did all of those things, we ended up, at least in culture system, again, I don't want to give you a headache with all the slides, but this is GP91, and that shows we were able to get 31% of the cells in culture in our best go around with this. Well, that's certainly above our 20%. The problem, though, is when we took these cells and now loaded them into mice, so there's a kind of mouse that will accept a human cell transplant. So it's sort of like, you can't just do this stuff and then try it on people, and you can't trust that what you look at just in the test tube is working. So we and others use these mouse systems that will accept human cells, and so we can. It's sort of like a mini human experiment with the human cells, and in the mice long term, we were, in this experiment, what we're showing is that about 21% of the cells were expressing GP91, which is the missing protein in the neutrophils, human neutrophils that developed in the mice. The problem, of course, is that we get a lot of variability, and where we are with this is that in the mice, long term, which is what really counts, we're routinely getting 10% or so. Well, that's not quite good enough to go to the clinic, but we're pretty excited about it, and we're seriously considering whether, if we do this to the point where we can get routinely 20% over and over and over again, that we might actually be able to do a clinical trial in which we treat some of the patients who have this specific mutation. We're also working on other approaches that will apply more broadly to all the different forms of CGD. And I'm going to skip this last slide, which is sort of, well, actually, it's a slide worth showing just to show you one. This just shows you that in some of our optimum studies, if red is a healthy donor, meaning, so we're looking, what we're doing is taking the cells and doing high throughput sequencing, so we tell what cells at the site of the cut have been repaired, what cells have what we call non-homologous end joining, meaning the 5-year-old that was physically take. So we've actually, if you've got a mutation that doesn't work, if you destroy the site, it doesn't matter. And how many are left still with the mutation? So the mutations in blue, the correct is in red, and the non-homologous end joining is in red. And you can see that we've got, in this experiment, we're hitting, over 20%. So we've been able to show this from the mice, not only at the functional level, but also at the genetic level, that we can get in the range that if we can make this work over and over and over again, and we can scale it up, we might be able to actually do this to benefit patients. So this is just sort of a quick summary, and we'll stop. So we've achieved gene editing of this particular mutation, correction of patient cells long-term in mice, averages about 10%. Some experiments approaches 30%. Well, this exceeds our minimum target of 10, although I'd like 20, required to begin to consider clinical application. I would like to see us always exceed 10% and ideally greater than 20% before going to the clinic. But what I'm hoping to do today is, A, to teach you something entirely new that's not going to affect your lives in the next year or two, but that gives you some hint as to where this is going. So we've finally got working gene therapy with vectors, and maybe that will get to be available to everybody. We've got transplant for some patients, and now we've got this new gene editing that I think, over the next 5-10 years is going to really change the entire field. And I thank you.